Assalamu alaikum wa rahmatullahi wa barakatuhu. A very good day to all the delegates who have assembled here, logged in to reuniting to experience one of the most awaited CME program of the year, which is ARDS, the Complete Symposium, organized by Indian Academy of Pediatrics, UAE chapter, led by Dr. Rajiv and his team. So the scientific committee consists of Dr. Rajiv, Dr. Deepu, and Dr. Sridhar Kalyan Sundaram. Myself, Tawfiq Ali, the Country Business Manager of New Country Healthcare. So I would like to introduce Dr. Rajiv to take over the proceedings of the program. Dr. Rajiv is the president of the IAP Emirates Chapter, and he is a specialist pediatrician or pediatrician neonatologist working at Health Hub Group. So Dr. Rajiv, please. You are mute, doctor.
Have everybody joined, Tawfiq?
Yes, doctor, you can go ahead.
Good evening to you, all of you. It is a very important CMB we conducted today, and I'm most fortunate that we have one of the world's most research group headed by Dr. Peter Rimmensberger, Dr. Flory, Dr. Daniel De Luca, and Dr. Martin Kreiber. They have a part of the textbook which is very elite and well read and researched all over the world. I selected this topic because it affects almost all specialties of pediatrics, and it's an end-stage process in which it is difficult to come out, and we are so fortunate that this excellent, well-researched group, according to me, possibly the best in the world available, is going to give us this CME on this most important topic of pediatric intensive care. Let me also thank all the presidents of the societies, which I am amazed when we go through. Indian Academy of Pediatrics, almost 30,000 pediatricians. National Neonatology Forum President next year, Dr. Praveen, is with us today. We welcome you, sir. Then we have President of Indian Academy of Pediatrics 2018, my colleague, Dr. Santosh Sons. We welcome you, sir. And we have Dr. Junaid, who is one of the most influential educated programs connected to Mayo Clinic with us. Junaid, we welcome you. Then we have our senior faculty, Dr. Iqbal Memo, who is the president of the APPA, which is the Asian Southeast Pacific for Pediatric Intensive Care. And that's a huge network we have here. So with this, and I want to introduce Dr. Kiran also, who is the head of, president of the Indian Society of Pediatric and Neonatal Intensive Care based in Qatar. So we have a huge resource of terrific academically programmed people with us today. So I flag off this conference with a speech from our elite president, Dr. Ramesh Kumar. Ramesh, over to you.
Thank you, Dr. Rajiv and Dr. Tawfiq. President, the Indian Academy of Pediatrics Emirates Neonatal Chapter, Dr. Rajiv, and Secretary Dr. Sridhar Kalyan Sundaram. My president, when I was a Secretary General of Indian Academy of Pediatrics 2018, my president, Dr. Santosh Sons, and President of APA, we are very fortunate to have Dr. Iqbal Mamam here. It's a wonderful evening here, where we have got, as Dr. Rajiv said, a complete symposium on pediatric ARDS. And I mean, when you, I'm very happy that this topic has come for a complete discussion here today. And for ARDS, it has to be complete, as it is various domains are involved. And ARDS was something which it's basically an heterogeneous origin. And possibly till 5-8 years back, a clear definition was lacking. And of course, pediatric ARDS varies from that in adults. And as you all are really thorough about it, pediatric ARDS was built in through the definitions. This is an important syndrome which, through thoughtful and astute clinical observations over the years, the definition itself has to evolve over a lot of, I think, historically looking at it. And now we have got various facets of this ARDS, and it has to be complete. This symposium will make it complete through the various topics which has been taken for deliberations here. And more importantly, as Dr. Raju has noted, it is a complete amalgamation of various organizations here who have been represented in a big way. And we are so happy that Dr. Praveen Kumar is here as the president of National Neonatology Forum. And at this moment, I must correct Raju. Dr. Raju, we have got 35,000 pediatric members in Indian Academy of Pediatrics right now, not 30,000. So we are growing very fast right now. And we have got Dr. Daniela Di Luca from the European Network of Pediatric and Neonatal Intensivists, as well as Dr. Khairi Latavi is there. So Arab Care Neonatal Group, his president is there. And of course, Dr. Memam is there. And the Indian Dr. Kiran Mora is there from Indian Association of Pediatric and Neonatal Intensivists. So that's all the various organizations are represented right here. And more than that, we have got the very important, very elite speakers. Professor Peter Riemensberger is here, the renowned faculty from Switzerland, and Dr. Daniela Luca is here, Dr. Heidi Flory is here, Dr. Ibu Abraham, and of course, doctors apart from, so the faculty is an elite faculty, elite group, and I'm sure Dr. Junaid Khan has organized this in a big way. So that's a great team which has been behind this meticulous planning for the run up to the conference and for the CME. And I'm very sure, certainly, this is going to be a complete symposium on pediatric ARDS, and the various phases will be well deliberated, and that will equip the clinical, the intensivists or the critical care persons working in the pediatric care to be better equipped and better thoughts on what they are dealing with and how best they can manage on all frontiers of that ARDS. So I wish the symposium a total success out here, and the very excellent academic deliberations. And I'm so happy to see that the symposium is flagged off at this moment to this great evening. Once again, my best wishes and congratulations to Dr. Rajiv. I have seen the way he has been working for this neonatal care, and I read about him because I have seen him from 2002, I think, when he was in Amartha Institute, Cochin. And we have heard about his passion for neonatology from that moment, the way he was taking sildenafil, some research on those topics. And he has come out with his literary works also, a lot of publications. Last year also he had an entire great publications from the textbooks from his side. So we are really proud about the way the Neonatal Emirates Neonatal Chapter is taking shape. Great strides under the care of this eminent academician and organizer, Dr. Rajiv. Of course, Dr. Sridhar is also to support him, and all my dear friends out there. So academicians in UAE and Qatar and all the Middle East are also grouping together. So it's a great moment for Indian Academy of Pediatrics, and my greetings from the Central Office of Indian Academy of Pediatrics, the office bearers and executive board. And on behalf of 34,000 members of Indian Academy of Pediatrics, we extend my sincere greetings to all the office bearers of the other organizations, representatives of the other sister organizations of the fraternity, as well as the great faculty here, and all those who have joined on this virtual platform here today. Once again, my best wishes, and wish we have a great going. IAP. Thank you. Thank you, sir.
Yes, Dr. Rajiv, you are mute.
Yeah, thank you, Dr. Ramesh, for such a good introduction and best wishes. We proceed further. Now I request my colleague, esteemed Dr. Sridhar. He is a very low profile but high intensity intensivist, and he has got a good grasp of the neonatal intensive care, and he has been my secretary silently for some time now. So without much ado, I request him to felicitate Dr. Peter Riemensberger, who is my idol for last 20 years. I really wish I could have been a student, but I'm a little bit older now to go back for training. So Dr. Peter, we want to felicitate you today on this August occasion by Dr. Sridhar.
Thank you, Dr. Rajiv. Good evening, everyone. We are very lucky to have such esteemed speakers, and we have the pleasure of having Professor Praveen Kumar, who is my teacher as well in Chandigarh. And as Dr. Ramesh clearly pointed out, Dr. Rajiv has been relentless in his pursuit of teaching the basics of knowledge to everyone, and the series of CMEs that he has organized, I think I would say single-handedly, I'm helping him, but he's the main one behind all of these. He's the brain, and he's in touch with the great stalwarts like Professor Peter Riemensberger as well. And today I have the privilege to felicitate Professor Peter. Dr. Rajiv, you are missing out an opportunity to stay in Geneva, which is one of the most beautiful places, and Professor Peter is working there. So there is no age to learn, and to learn from a person like Dr. Peter is an opportunity. There is no age limit for that. And I'm sure he will welcome you anytime. So Professor Riemensberger is the Director of Neonatal Services and PICU at the University Hospital of Geneva. He is board certified in pediatrics, neonatology, and intensive care medicine. He is a full professor at the medical faculty of University of Geneva. He trained in Switzerland as well as in the Hospital for Sick Children in Toronto. He has a great passion for neonatal ventilation and pediatric ventilation. His lectures on ARDS are very popular in almost all the conferences, the PICU-based conferences I've attended. So his interests are respiratory physiology, respiratory failure, cardiopulmonary interactions, well-known expertise in mechanical ventilation. He has published more than 150 peer-reviewed articles. He has edited the textbook, Pediatric and Neonatal Mechanical Ventilation from Basics to Bedside, which has now become a standard source in many units worldwide. He has organized many scientific events and continues to do so. And he also organized the World Conference of Pediatric Intensive Care in the year 2007. And subsequently, he has been Executive Committee member of the European Society of Pediatric and Neonatal Intensive Care in various times between 2002 to 2019. He acted as a medical president of the society from 2015 to 2017. And in the year 2021, he received the prestigious Dennis De Victor Award from the European Society of Pediatric and Neonatal Intensive Care. You can watch this lecture on the YouTube as well. And he has great commitment to teaching. His approach is very simple. So his book, the name of his book clearly says From Basics to Bedside. So you have to have a clear comprehension of the basics. And I have been lucky to attend a few of his talks, both at Dr. Junaid's conference and in the conference in Al Jalila Hospital a couple of years ago before the COVID started. He has a great approach, very simple. And the way he stresses on pathophysiology, I think learning from the basics is the best way to remember it for life. And no words can felicitate an excellent and committed teacher like Professor Peter. We are lucky to have him here. I don't want to stand between you and his next lecture. So thank you so much for the opportunity to introduce him, and welcome Dr. Peter, and look forward to a great lecture from you.
So thank you, Dr. Sridhar, for this nice, overwhelming introduction. And you're right, basics is the most important thing, in my opinion, in the pediatric ICU. So welcome to everybody, either it's evening, it's afternoon, or it's in the morning. You asked me to talk about an additional topic as a keynote lecture, so 4 decades of ARDS. I just will share my screen and hope this works fine. Okay, so I was asked to talk about 4 decades of ARDS. Where are we now in 2022? I have no conflict of interest to declare. And what I want to talk about is the history of a syndrome and its treatment over these years. So in 1967, it was Ashbrough that introduced the first time a concept of ARDS, describing a series of 12 ICU patients who had in common persistent tachypnea, hypoxemia, obfuscation on chest radiographs, poor lung compliance, despite different underlying disease. Inconsistent definitions led, however, over the years to different published prevalence in ICU, range from 10 to 90%. So you see the definition was not very clear. And interestingly, already in 1989, there was the group from Roger Fay who described a similar syndrome in full-term newborns. They showed diffuse bilateral infiltrates, had acute hypoxic respiratory failure, had an acute perinatal triggering insult, and were on continuous positive pressure ventilation with severe hypoxemia. And also at this time, there was a mentioning of a PEEP of more than 6 centimeters of water. Shortly after, a previous teacher of myself, Jörg Pfenninger, when I started my fellow training in the ICU in Bern in Switzerland, was describing under the title Paradox of Adult Respiratory Syndrome in neonates a series of 6 full-term infants that showed exactly the same syndrome, and they did histologic examinations that revealed typical changes of acute or subacute stages of ARDS described in the adults. So we learned over time that ARDS is not a disease, it is actually a syndrome of acute respiratory failure, which is characterized by inflammatory pulmonary edema, hypoxemia, and decreased lung compliance. And the classical time schedule, or what's happening over time, is first we have an exudative stage, so an inflammatory phase with edema formation, and very early on already hyaline membranes formation in histology. And from about 7 to 8 days, it switches more in a proliferative stage with predominant interstitial inflammation and interstitial fibrosis. Over the times, then people start to try to do severity definitions, with 1888 by Murray, the acute lung injury score. And this score already at this time had the chest X-ray, had hypoxemia score, had criteria on various PEEP levels as a severity grading and a compliance score. And in 94, then the AECC actually defined in a first attempt acute lung injury and ARDS with the diagnostic criteria for an acute onset, oxygenation troubles, X-ray modifications with bilateral infiltrates, and they also added at this time already or excluded the cardiogenic edema as a cause that would not qualify as an ARDS diagnostic. They already introduced a first severity grading with acute lung injury with a PF ratio below 300 millimeters of mercury and ARDS with below 200. So oxygenation criteria at this time were independent from PEEP. Then in 2012, the famous Berlin definition of ARDS came up that is more or less still actually used in the elder population. We again timing definition, chest imaging definition, origin of edema excluding cardiac edema, and severity grading, mild, moderate, or severe ARDS according to PF ratio. And what they included at this time was a minimal PEEP level as a condition to judge for oxygenation problems. And this kind of definition allowed with mild, moderate to severe to distinguish between mortality or predictive mortality for its patients, so ranging from mild from 27 to severe to 48. So the grading or the severity grading has become useful for doing studies and predicting outcome. In pediatrics, we tried, Daniel Zulekha and other groups tried to validate this adult definition, the Berlin definition, and they could show both that actually it worked for severe ARDS, so lower survival for severe ARDS, what was predictable, but not a differentiation between mild and moderate. And you see the same here in this study from Pravantanen, who actually showed also no really distinctive differentiation between mild and moderate in terms of predicted outcome compared to severe. This brought then the PALIC group, the Pediatric Acute Lung Injury Consensus Conference in this year 2015 up to have a more specific PARDS definition, including the same criteria, timing, origin of edema, chest imaging, with the exception that bilateral was no more requested, and then oxygenation also for non-invasive mechanical ventilation, giving an SF ratio at the minimal PEEP of 5, or then in invasive mechanical ventilation, mild, moderate, and severe according to oxygenation index or the oxygenation saturation index. The oxygenation index was chosen in the pediatric setting as the PF ratio is not only influenced by PEEP, but also by the inspiratory pressure. So the mean air pressure in the formula seemed to make sense and has been used for many years in the pediatric population, our definition. Exclusion criteria, special conditions, they added cyanotic heart disease with acute deterioration, chronic lung disease with acute deterioration, or left ventricle dysfunction with acute deterioration of oxygenation due to respiratory problems. And this kind of severity grading the parts was actually allowing to get with mild ARDS a relationship to outcome about 10% of mortality, for moderate ARDS about 20% of mortality, and for severe ARDS ranging from 35 to 45 of mortality, and Pravantine could show the same, they confirmed this data. Shortly after, now we have the neonatal ARDS definition from it, which we created and discussed with many experts in Montreux in 2015 and was then published 2017, where we actually did the same thing: time frame, exclusion criteria, lung imaging, origin of edema, and oxygenativity expressed by the oxygenation index. And there is actually a validation study being done, and is submitted for publication by Daniele Zulekha and our groups. So we'll know soon how valid this definition is, but it seems to be quite well for defining severity grading in relation to outcome. So what we observed over years is a heterogeneity of clinical conditions associated with ARDS, variance in outcomes by risk factors, etiology, and severity grading. And we learned also that it's not simply a common pathologic pathway, but might be a collection of pathways of injury. For example, as you may already know, the concept of pulmonary and extrapulmonary origin. So we have a syndrome already with 2 or more phenotypes. The classical phenotypes: direct insult, pulmonary etiology, so pneumonia, aspiration, inhalation injury, and others, and indirect insult, the extrapulmonary etiology, so patients with sepsis, severe trauma, shock, acute pancreatitis, or post-cardiac bypass. Interestingly, the same was observed by Ashbaugh in 1967. He described in his series the illness origin, so multiple trauma, corresponding to indirect insult, extrapulmonary etiology. And you see many patients were in these groups, where others fitted well in the direct insult pulmonary etiology. So somewhat we had overseen at this time that there are various etiologies behind, and that we do not talk about a disease in ARDS, that we have to talk about a syndrome associated or in result of various etiologies. Furthermore, Calfee in 2014 was actually publishing an excellent study. They were looking in the adult respiratory distress at the ARMA cohort, so the one that was 6 versus 12 meter compared as a tidal volume, and the alveoli cohort from a different study from the adults, that were 2 distinct phenotypes as defined by expression of inflammatory or pro-inflammatory cytokines, as expressed by response to PEEP and oxygenation, and actually expressed to different biochemical markers. And you can see there were 2 distinct phenotypes in both groups, similar. So those who had low pro-inflammatory cytokines expression and those who had high pro-inflammatory cytokine expression, and they did not behave the same in terms of PF ratios or in response to PEEP or other parameters. Exactly the same for the alveoli cohort. So 2 different phenotypes in terms of the expression of pro-inflammatory chemokines, biochemical markers, and response to various ventilation parameters. And if they look then in the type of what were the clinical situations around, so phenotype 1 did not require a lot of vasopressors in the clinical setting, whereas patients with phenotype 2 were most of them under vasopressors, and this was identical for both groups. And you can see also here that For example, phenotype 1, sepsis as an origin was much more seldom than in phenotype 2, and these for both groups. So there seemed to be some correlation between phenotypes, expression of disease, and even the etiology causing finally the syndrome of ARDS. Furthermore, they showed that phenotype 1 and phenotype 2 showed different outcomes. So for the ARMA and the alveolar cohort, phenotype 1 was associated with more ventilator-free days, so shorter ventilation times, was associated with more organ failure-free days, so less organ failure, and showed clearly a low mortality for it. And this also, the alveolar group, exactly the same than phenotype 2 patients. And interestingly also, the difference in response to PEEP, according to the phenotype. So phenotype 1 actually benefited much more from low PEEP settings, whereas phenotype 2 benefited from high PEEP settings in terms of mortality. So this shows us that in this syndrome, we just cannot use a simple parameter to know what we should do. And this brings us to the conceptual framework of ventilator-induced lung injury. So mainly known as the volar trauma concept and the adalect trauma concept. And you can see here that we have the lung injury from in the volar trauma by the concept of lower distension and shear forces exceeding the forces on the lung tissue, so a direct physical injury. And then the concept of mechanotransduction is expression of pro-inflammatory cytokines in the systemic circulation, so the so-called biotrauma. We have the concept of repetitive opening and closing and shear at open and collapsed lung interface. And it has become clear that these two things, so the biophysical injury, what we talk about when we think about mechanical ventilation parameters, and biochemical injury induced partially by the way how we ventilated patients, but also on the pre-existing disease that led to ARDS, will have an effect on what happens to the systemic circulation, to distal organs, and to multi-systemic organ failure. So the systemic inflammation is the cause for death. So the systemic release of cytokines, endotoxin, bacteria, and proteases. And I remember my old first chief in pediatric intensive care, Jörg Fenninger, he always told me, ARDS patients do not die from hypoxemia, they die from systemic multi-organ failure. And this has been nicely shown, this correlation between used ventilator parameters and here the expression of pro-inflammatory cytokines, interleukin 8 and 6, and the correlation to mortality. So protective ventilation characterized by smaller tidal volumes, higher PEEP levels, and more limitation of inspiratory pressures or resulting inspiratory pressure due to smaller tidal volumes showed lower mortality than those who were ventilated in a control way, so closer to this 12 ml per kilogram. And there was an association clearly with expression of cytokines. So the protective group expression of cytokines reduced within 24-40 hours for IL-8 and IL-6, where it did not or even slightly increase in control group. So this shows the correlation between vent settings and the systemic reaction in terms of cytokine expression. So in the 19th, when we go back, we started to recognize that the inspiratory pressure or plateau pressure might be potentially harmful. This is the classical study from Parker, who showed that the coefficient of edema formation was drastically increasing in ducts when ventilated with plateau pressures higher than 30 centimeters of water. Didier Dreyfus opened us the eyes by showing just a simple experiment, ventilating isolated rat lungs at very high pressures, plateau pressures. Within a few minutes, there was actually illness and first atelectasis happening, ventilated for 20 minutes, severe edema, hemorrhage, edema in these lungs. So they destroyed the lungs within a few minutes just by applying high pressures. From the clinical setting, we got the data from Jardin in 1999, who compared a cohort of patients 93 to 96, where they used high inspiratory pressures, and a group before, the group in 96 where they used low inspiratory pressures, and a group before, historical group, where they used high inspiratory pressures. And you can see the difference in outcome, much better survival by reducing inspiratory pressures. And also several studies in the pediatric field in these years showed a clear trend that when you, with lower inspiratory pressures, survival rates were higher. So lower inspiratory pressures with the red, that's the survivors, and the non-survivors with the yellow columns here. So having higher inspiratory pressures, higher mortality. Recognition of potential harm for PEEP was also coming very early on. So Matami showed in 84 that according by PEEP titration according to pressure volume was associated with all of a sudden an increase in oxygenation or a drop in pulmonary shunt. And this was happening what we coined then later on as the lower inflection point of the pressure volume curve. Matami's or Muscadere's group in a lab in Toronto, where I had the chance to work later on, showed then that the PEEP pressure had an influence on outcome independent of small tidal volumes used. Here, PEEP of 0, PEEP of 4, PEEP above this inflection point, and the control group in rats that were depleted from surfactant and ventilated over some time. He could show that the pressure volume curve dropped down after 4 hours of ventilation, indicating a lot of cellular infiltrates and reduction of compliance. PEEP of 4 the same, but when PEEP was used above the inflection point, there was no change over time, so no harm induced. And similarly, and this is the paper from Tremblay, they showed that when you use different PEEP levels, use different tidal volumes, the association of both seems to be important. So the worst in terms of cytokine expression was 40 mils, or the large tidal volumes at 0 PEEP. The best was small tidal volumes at a slightly elevated PEEP. And you can see even when you use same tidal volumes, PEEP became important. So PEEP of 10 was more protective of PEEP of 0 despite using same tidal volumes. And when you compare then these two groups, so both were matching the same plateau pressures, 40 mils per kilo of tidal volume, 0 PEEP, or 50 milligrams, 10 PEEP, there was a big difference in outcome. So the recognition at this time, it is not one single parameter. This brings us to the ARDS network study. So what did we learn from clinical experience? Tidal volume is important, but also we had to observe that 6 versus 12 was not the only thing that was different between groups. There was also a big difference in inspiratory pressure and plateau pressure. So is it tidal volume or is it pressure? Or is it because they used also a PEEP titration concept of recruitment? Is it PEEP? And interestingly, this study showed a number needed to treat to have a benefit of 6 versus 12, including the PEEP titration PEEP titration schedule. That number needed to treat was 14. So 1 out of 14 patients had a benefit. And the others did not. And when you look later on a bit more in detailed retrospective analysis from the same studies, the deans could show that patients that had poor compliance benefited from 6 mil per kilo with clearly lower mortality, but patients had good compliance, they benefited more from 12 milliliter per kilo than from 6. Outcome was worse. So what did we forget? We did forget the concept of the baby lung, which shows the relation between compliance and residual inflated lung volume, so the percentage of exit normal volume. This volume is smaller, the smaller the compliance, and is larger, the larger the compliance. And interestingly, with the use of NAVA, Brande showed them that the patient with ARDS, when you let him control his tidal volumes by himself, by this closed loop concept. So the worse their compliance, they choose the smaller tidal volumes, the range 4 to 6. When compliance get better, they go up to 8, 9 ml per kilo, which is the upper end of physiologic tidal volumes. So what did we overlook, oversimplify? We did overlook the consequence of the baby lung concept, which is finally nowadays actually expressed by the concept of limiting delta pressures. You see the same delta pressure when the severely ill lung will result in smaller tidal volumes. We cannot allow for more time because otherwise we are over-distend or let collapse the lungs. Whereas in a better lung, the same distending pressure will not bring you in the range of over-distension. So this is the reason that focus comes on distending pressure, as shown by Amato. More than 15, this will result with higher mortality. And this has been shown, this individual disease, the severity plays a role as well, with the alveolar study that showed that the driving pressure was the most associated parameter to outcome for moderate and severe ARDS. PEEP had some correlations, plateau pressures for the severe ARDS had some correlations, and tidal volume did have no effect on outcome for all the different disease severities of ARDS. Another example that we overlooked is the individual disease severity importance was with the survival. The prone studies in severe ARDS, they were for a long time negative, to the point where Guérin actually realized when only taking severe ARDS patient defined with below 100 milliliter of PF ratio, that you could show a difference for prone versus supine in outcome. And all the studies before, they were negative. When they only looked at their severe ARDS patient in their study, they could actually repeat the same result. So we had to learn that it's not just one single setting, that you be careful about severity of lung disease. And this comes back what happened during the COVID-19 pandemic, where the Gatinonis group actually started to describe two types. So the L type, the low elastance, so the patient with normal compliance but severe hypoxic respiratory failure, so made an atypical ARDS with viral pneumonitis initially, versus the H type, so the high elastance, which means low compliance and high recruitability, so the classical ARDS patient. And they were recommending that you should be careful for which patient you use PEEP. So in the L type, be careful with PEEP because you cannot recruit. In the H type, you should try to go along the PEEP FiO2 table from the ARDS network study and try to do some recruitments. However, over time, with more and more patients in this COVID-19 ARDS population, we realized that compliance goes all over the ranges for these patients. So there's some patients with good compliance, patients with low compliance, and this is a continuum over time. It's not just two phenotypes. And this has just to be taken into account. What will we learn from this? That you have to take this in account according disease evolution during the course of ARDS. And this is actually already expressed in the PALICH recommendation, where we set tidal on 4 to 8 ml for patients, normal patients or mild to severe ARDS. However, when you have severely impaired compliance, you may allow for or should allow for much lower tidal volumes. Limiting the plateau pressure is always a safe concept, and using PEEP, the higher the severe the ARDS, and see if you see a recruitment effect, as we will discuss later. So what did we overlook, oversimplify? We oversimplified with our approach going towards randomized controlled trials versus the individual patient's physiological response. So if you take here just an example, These patients respond differently on a specific treatment. Here for a colon cancer, if you see 3 responded well, in 3 it had no effect, and 1 had even a severe side effect. So the number needed to treat is 2.4 here. Remember, the number needed of the ARN trial was 14, so 6 versus 12 ml per kilo. So we have to think about this personalized medicine as a future vision, and we have to think about what is the patient's individual response, which treatment does he need, which ventilator setting, for whom. So we have to test the patient, we have to understand the patients, their physiologic response on what we do. Is it positive? Is there no response, or may we do harm? And we have really to think about this in the future much more, instead of coming just with simple guidelines. So personalizing the ventilator settings goes through the whole ARDS ventilation time from Ashbo, because he was based on a physiologic rationale, giving us the idea PEEP against aterectasis and for proving oxygenation. We had then later on Peter Subter's group that showed in ARDS patient that you should search for the best oxygen delivery, best compliance. We have then the Ranieri's group that showed pressure time curves, so using the analysis of mechanical properties of the respiratory system to understand what ventilator settings would be best. We had then the concept in 2006 to search for best dynamic compliance with recruitment approaches and see where you can ventilate on the deflation limb. And we had then again the best CO2 elimination, best compliance. We had studies on PV curves and lower inflection point, so using the pressure volume curve to set proper PEEP. We had then the concept of targeting transplant pressure to prevent ventilator-induced injury. But in fact, all go around the questions, where is my ventilator loop in the loop of the pressure volume curve? And this brings us to the concept, when we want to not cause harm, not to be too high, not be too low, we have to do some volume limitation, but we have to do some pressure limitation. So it means descending pressures, plateau limit, and PEEP are the important components. This requires an understanding of respiratory mechanics. It requires an understanding of the patient conditions. So what are the other things that happened over the last 40 years? We were repeatedly changing recommendation, the use of corticosteroids. We'll hear more about this during this symposium. Repeatedly, we were changing concept of the use of surfactant. We also will have more about this. We used various attempts of using nitric oxide. Most of them failed. Many attempts of various anti-inflammatory treatment concepts that all failed in the past. We had all the time changing paradigms on the use of neuromuscular blockade, again, an ongoing study now planned in the pediatric field. We are changing paradigms on the use of prone position. It has become clear nowadays that probably only the most severe ARDS patients have a benefit out of it. Euphorism and repeated frustrations on the use of HFOV. We will hear more about this. And we also observed an increased use of respiratory ECMO. Thank you very much.
Hello. Tawfiq?
Yes, doctor. So there are a few questions.
Shall we move on with the CME and keep it for the question hour topic? That's better, no? Let everybody attend the sequence and...
So you mean to say like you will answer the questions in the end?
Yeah, that's better.
Yes, confirm if Professor will be available through the session. Professor Peter, will you be available throughout the session, or do you have any commitments?
Or Doctor, what I feel like after Dr. Peter's second lecture, during that I can
combine together. Okay.
Yes,
yeah,
that's better.
Okay, doctor. So let's move on to the next one.
Taufik, shall I introduce the next
Yeah.
chairperson?
Yes.
This is our young and dynamic Dr. Kiran Moore, who is the president, another president, very inspiring president of the society called INSPIRE, Indian Association of Pediatric and Neonatal Intensive Care. He's doing excellent work in Sidra, but when I went through his profile, it is an extremely impressive profile. He's a neonatal consultant, lead of cardiac and ICU, ECMO education and clinical guidelines, assistant professor of Cornell University, Qatar. He was former neonatal consultant at Christchurch Hospital, New Zealand. He was global clinical scholars research training, Harvard, neonatal fellow, Royal Children's Hospital, Melbourne. He has been around for quite some time, and despite being such a pleasing personality, I did not see the intensity of his academic excellence. So over to you, Kiran. You are dealing with my old colleague and equally famous pediatric intensivist, Dr. Santosh Sones. Over to you, Kiran.
Thank you, Rajiv, for the nice introduction. So good evening, everyone. So after this excellent session by Peter giving an overview of 4 decades of ARDS, let's move on to the next session, which is very important and will set the foundation of today's sessions, which is on the pathophysiology of the ARDS. So to present this topic, we have a very elite faculty from India who needs no introduction, especially amongst the Indian pediatricians and neonatologists, Professor Santosh Sones. He's a professor and head of the department in Chief of Pediatric Intensive Care and Neonatology at AJ Institute of Medical Science and Research, Mangalore. I admire Professor Santosh for his great personality, leadership skill, and he's a very captive speaker. I've heard him in few conferences, and it's amazing to see how he engages the audience and inspires them. And I'm sure he has very big fan following. And as Rajiv mentioned, he's very famous amongst the Indian pediatricians. He has honored many important leadership positions in various organizations, both locally and at national level. Of note, he was a president of Indian Academy of Pediatrics in 2018. And in the same year, he was also a founder president of Organization of Medicine Guild. This was, again, a novel concept which was initiated with a clear focus to work with the government of India in its mission to achieve the highest benchmarks in health and also help development of policies and practices. So he's really led a good initiative and has gathered a lot of organization under this, this one organization. And he's received prestigious awards such as Outstanding Asia Pacific Pediatrician. He has authored 5 books and has numerous international publications. So without delaying further, I would like to invite Professor Santosh Sones to deliver his talk on pathophysiology of ARDS. Over to you, Professor Sones.
Yeah, I'll just share my screen.
Sure. Perfect. Yes.
Good evening to, good evening to everybody. It's great introduction, Kiran. Thanks a lot for that. And it is very nice to be in the with all my friends, especially Rajiv. We did our MD together in Mangalore. He was my senior, and I learned quite a bit from him. And his passion, I think the passion what he has is something extraordinary. I think the same way he has worked in neonatology. And it's so nice to hear one of the giants of especially ARDS in the pediatric field, Peter, and the work which he has done. So I'll be just going through the pathophysiology because this is the, as Kiran said, it's the foundation of what really happens. But I'll keep my talk too simple because a large number of them is general pediatricians who are not a pediatric intensivist in this field. I think we have gone through the disclosures are none for this topic. And if you see, Dr. Peter has already told about the definition of this thing. It's a syndrome of acute diffuse inflammatory lung injury associated with a non-hemodynamic lung edema. See, basically you get 2 types of edema. One is because of the left heart failure or sort of a obstruction to the pulmonary venous drainage. That's the reason why what happens is you get a non-protein rich fluid into the alveoli. Second one is direct because of the infections or direct injury to the alveoli, you have a protein-rich fluid coming into the alveoli. Basically, the definition is whatever it is that consists of three things, which has been long time back has been described. That is the non-cardiogenic pulmonary edema. When you see the X-ray, there is bilateral pulmonary infiltrates, which also have hypoxia because heart is normal, but because of the lungs, because of the extraction of oxygen, you get hypoxia. And also in the absence of heart failure, that is very important. That is, you don't have a heart failure. It is non-cardiogenic error. And this, I think it's one of the causes that is, as you know, it's been described that direct or indirect injury. Because direct is alveolar or epithelial injury. What happens is that common causes of direct lung injuries are basically pneumonia, aspiration of gastric contents. Because here what happens is that whatever the cause is, like for example, pneumonia, infection, it causes injury to the alveolar epithelium, which results in the further cascade of problems what happens in the alveoli. Second is indirect. It is not related directly to the alveoli, it's somewhere else, like something like sepsis, severe trauma, shock, and multiple transfusions. So majority of cases of AR, this is coming to the pictorial form, that is, as you see, like aspiration. One of the most common causes of pediatric is aspiration. More than that is pneumonia. Almost about 30% of ARDS, what we see in our PSUs because of the pneumonia. Then others like neo-drowning or direct injury, as I said, toxic inhalation injury, blunt injury. These are the ones which causes the direct alveolar damage resulting in ARDS. There is indirect injury, that is somewhere else, not from the basic lung alveoli, but it is occurring somewhere else. Most often is the sepsis, which forms again around 32 to 35% of the cases which presents with ARDS in pediatric age group. What happens is here, because of somewhere else, there is cytokine storm, which produces this inflammatory wall-like situation, which is overwhelming, which releases so many of these cytokines. So causing the indirect injury to the endothelium of the capillaries, which results in the alveolar damage and further problems. So coming to the epidemiology. So this is basically an adult study which was produced about 32% sepsis and pneumonia. The sepsis, pneumonia, what I mean is not sepsis. What I mean is that it is not the pneumonia, the organism which is causing sepsis further causing this. This is sepsis somewhere else, resulting in ARDS. Aspirations form about 17%, trauma forms about 13%. So this is a party study which has been sort of told by Dr. Peter, that is about 145 intensive care units from about 27 countries took part in this. There were about 23,800 admissions, out of it about 3% had pediatric ARDS, with about 17% of mortality, because though it was admissions were only 3.2% of ARDS was there, but it found about 17%. Earlier reports showed almost about 30%, though the admission was anywhere between 1 to 3% of this. So coming to the basic thing about the pathophysiology or pathobiology. Basically, what happens is there is diffuse injury to the alveolar epithelium. And also, what happens is indirect injury. It is because of the capillary endothelial barrier. It's sort of a disrupted, resulting in a non-cardiogenic pulmonary edema. Let's come to that later. So what happens is that when there is an injury because of the cytokine storm, there is infiltration of the activated neutrophils into the alveolar space. What happens is there is the barrier of the endothelium which gets disrupted. So you have a alveoli. Actually, see the wonder of the nature. You have a sort of a completely dry alveoli, which is sort of a hanging in the basket filled with blood vessels. you have completely fluid-less alveoli, and you have a completely fluid-filled capillaries. So somehow it doesn't go between two, so it remains dry, and here it remains filled with blood. So what happens is, because of this activated neutrophils, which sort of, because of the disrupted endothelial barrier, gets into the alveoli and causes this thing. This is a hallmark of ARDS. This is a slide which shows basically what in a child who has got a ARDS, which shows a dilated alveoli, which during this proliferative phase, what happens is there is initial dilated alveoli. There is, you can see this pink area, which are the hyaline membrane disease. And there are the areas, because what happens is in ARDS, there are areas of a normal lung, there is areas of a collapsed lung. There is also atelectasis, which is happening, or the involved lung. So in a given child with a ARDS, you have both a normal lung and a diseased lung. This again, this pink areas, what you see is sort of a hyaline membranes which are formed in this. This again, you can see in this pathology slide, that is, these are the alveoli, what you see here, which is filled with the proteinaceous material, the infiltrates like monocytes and neutrophils. And here it is just getting aggregated with this proliferative cells, which is on the side. And this is again about 200 into 200 slide, that magnified 200 slide. Here you can see the deposition of this fibrin, which is producing the thickening of the alveoli in the later stages. Coming to the phases of disease that we all know, that all the pneumonias or this thing, they goes through these phases. So whatever the inciting injury which occurs, whether it's direct or indirect, the ARDS commonly progresses to the stages, because each one has got a different clinical manifestation. They have a different radiographic manifestation, and there is different histopathological features in this different stages. So what are the phases? Because here, if you see this picture, this sort of is a normal alveoli. You can see on the sides, this is the type 1 alveolar cells, and these are the type 2 cells, because you can see it is more flat, more squamous, and this is more of a cuboidal shaped cells. And it is completely free of, almost completely free of the fluid here. But what happens is that when there is capillary endothelial destruction, barrier destruction, or when there is a direct injury to the alveoli. So what happens is, these are the macrophages, which sort of gets activated and calls the neutrophil inside, which can go because of the endothelial destruction, and the neutrophils migrates into the alveoli. So now what it does is, it sort of produces interstitial flooding and coagulation. In the proliferative phase, what happens is there is increased and interstitial fibroblasts will come in, and finally in the fibrotic phase, what happens is there is interstitial and intraalveolar fibrosis, which occurs so that the alveoli loses its compliance, and usually it does not have the same architecture as the normal type. So if you see this picture, here you can see this is on the top part of the alveoli. These are the bronchial epithelium. So as the bronchioles come down, you can see this bronchial epithelium. Then these are the flat ones, are what are called as a type 1 cells. So type 1 cells are the ones which sort of line the alveoli, and the main function of it is to sort of in the gas exchange. It's an impermeable membrane. So here, these are the type 2 cells. Type 2 cells have got a function of producing surfactant, and also for some this thing, it sort of allows fluid to pass from the alveoli into the interstitial space between the capillary endothelium and the alveoli. So whatever fluid which comes out, sort of in the interstitial space, gets get absorbed through the lymphatics into the capillary and gets out. Now what happens is, if you see, this is the normal alveoli on your left-hand side, which has macrophages, alveolar macrophages, and this whole area is devoid of any fluid. But what happens here is, in the exudative phase, because of the disruption of the endothelial wall, and also whenever there is a organism, pneumonia occurs or sepsis occurs, these antigen, as it comes into the alveoli, it the macrophages recognize it. They have what is called as a toll-like receptors on the top of it. It gets attached to that. Once it gets activated, it will release IL-1, TNF-alpha, and all these substances, granular enzymes and all that. This, what it does is a macrophages call the neutrophil inside, because there is also disruption of the endothelium of the capillaries. So what happens is, there is disruption. So all this thing, neutrophils goes up. When the neutrophil goes up, goes into the alveoli, it produces severe cytokine storm-like situations, so many enzymes and all that are relieved, and there is severe inflammation which occurs. So to kill the organism or neutralize the antigen, but there is a lot of other things which is happening. And see here, this is the type 2 cells. It loses its ability to push out the fluid, and that's the reason why there is a lot of fluid which occurs. When there is this reaction which is happening, there is a lot of hyperpermeability occurs, and the dry alveoli start getting right, and the protein-rich, like a gel-like consistency fluid is formed in the alveoli, which is not drained. Whereas in left heart failure or a cardiogenic edema, what happens is this protein-poor fluid, but here you get protein-rich fluid in the thing. This is again a diaphragm, which what really happens between the alveoli and the endothelium layer during the exudative phase. Here you can see that there is increased alveolar capillary permeability. You can see the disrupted, what we call as a V8 cardin. These are the bonds which between the endothelial, two endothelial layer, it is there and prevents anything going from the thing. So because this is disrupted, there is a fluid leak which goes into the alveoli and causes the problem. So coming to the exudative phase, it is characterized by acute development of a decreased pulmonary compliance and arterial hypoxia. What happens is, as the fluid comes in, protein-rich fluid comes into the alveoli, it's a surfactant production is lost because of the destruction of the type 2 cells. And also, it is neutralized also. So, yeah, as you know, the surfactant gives you a increase the surface tension, produces surface tension. So when it's decreased, the alveoli loses its compliance and loses its shape. When it happens, so there is arterial hypoxemia. So what are the clinical features in the exudative phase? They have tachypnea, they have a hypocarbia because of increased breathing rate, diffuse alveolar infiltrate on the X-ray due to pulmonary edema. So what happens at the alveoli? As I said, in a direct injury, that is that directly, like pneumonia, drowning, aspiration, etc., early pathological disruption of diffused alveolar damage. The initial effect is in the alveoli, which is suggested by predominance of alveolar epithelial injury in this direct injury to the lungs. This causes uncontrolled release of what we call as a damage-associated molecular pattern, because toll-like the receptors, pro-inflammatory cytokines, they're immediately released because of the attraction of the neutrophil inside the alveoli. So indirect lung injury, like for example, sepsis, acute pancreatitis, etc. What happens? There is cellular injury, whereas somewhere else, maybe you take it as the sepsis or abscess somewhere else. So it's a distant pathology which is there, which in turn, through the endothelium, it can damage the pulmonary endothelium and which sort of disrupt the alveolar barrier, resulting in dysfunction. And what happens is whenever there is so much of inflammatory cascade which is going on, there is also coagulation disturbances. And also what happens because of the microthrombus, the pulmonary vascular resistance increases, pulmonary hypertension increases. There is VQ mismatch, ventilation perfusion mismatch, poor oxygen, and also because multiple thrombus and inflammatory reaction, they can go in for multi-organ dysfunction. So coming to the capillary endothelium. So this capillary surface, to understand this capillary surface of the endothelial surface has got what is called as a glycocalyx layer, which sort of prevents any sort of a free passage of any substance. So injury to the glycocalyx is an important mechanism of increased alveolar permeability. What happens is it gets disrupted in the indirect injury. So restoration, because if you see as the resolution and the recovery of ARDS takes place, there is a restoration of glycocalyx, which results in the recovery. So this is a picture of what is a normal endothelium. You can see here there is a monocyte. This is inside the blood vessel capillaries. So platelets are there. You can see this beige colored sort of a thing from the endothelial cell till the up what is called as a glycocalyx. Now what happens is once the activated granulocyte comes here, it disrupts this glycocalyx. Once it disrupts, this injured endothelial cells becomes permeable. There'll be thrombosis, there'll be increased residue of core protein which occurs in this thing. Now coming to the next stage after the exudative phase, what we call as a fibroproliferative phase. This is basically when the repair starts happening. Because what happens is after about 7 to 10 days, the chronic inflammation and scarring of the alveolar capillary unit with increased alveolar dead space fraction happens. What happens is that because of the inflammation and scarring, the alveolar unit, because if you see earlier, it was like a balloon which is sort of a fully full of air. Now there is decreased dead space, which is some of them are atelectic and all that. So because of the thrombosis and mismatch, the refractory pulmonary hypertension can occur because the right to left shunt is occurring at that stage. So if you see this is from the proliferative phase as it happens because there'll be phagocytosis. Then what happens is these are the bronchial epithelium which is there. This is where there was the type 1 cells were there. This is the fluid, protein-rich fluid is there. This is basically what we call as a hyaline membrane. So here what happens is the type 2 cells, what happens is they can differentiate. They are mitotic, whereas type 1 cells are amitotic. They can't differentiate, they die. So these are the ones starts differentiating. So what happens is there, and as the inflammation starts subsiding, there'll be wound repair. The type 2 differentiates into type 1 alveolar cells, cell proliferation and difference occurs. And more important is if there's more injury, there is proliferation of fibrosis. That is fibrosis formation occurs. These are the fibroblasts from the endothelium starts getting here fibroblastic cells and start sort of depositing here wherever there is injured area and forms a sort of a honeycomb formation. So when there is severe injury, there is severe fibrosis which occurs, and with the deposit of fibronectin, whatever is cells, neutrophils will be there, then be taken up by the macrophages, cleared off. Same thing happens with the different proteins and other cells which will be cleared. Apoptosis occurs, all those things will occur. So stages, as I said, it's already been sort of dealt with the Dr. Peter, that is edema, which occurs in the first 2.5 to 3 days. Then the hyaline membranous formation from about a day to 14 days. Alveolar pneumocyte hyperplasia, which occurs, which goes on. and interstitial fibrosis feeds from the thing. This is an X-ray, which is a child will come initially. This is on the first day. Second is on the second day, you can see the infiltrates which are coming here. And third, this was on the fifth day, which occurs, it's almost getting like a whiteout lung. You can see in the different phases. Last one is where that's in the exudative proliferative phase, almost like a whiteout lung. So in the recovery phase, there is restoration of the alveolar and epithelial barrier. Whatever that barrier which is lost, where there's fluid coming in, neutrophils coming in, that starts getting sort of restored with the fibrin deposition and the repair. And clinically, the child will be gradual improvement in the pulmonary compliance, resolution of arterial hypoxemia, then finally return to the normal function. But some of them may not, because as I said, there are areas of normal lungs. There is also areas of dysfunctional alveoli. So these are the different phases, as I said, exudative phase, which is lasting for about 7 days, and proliferative phase anywhere between 7 to 21 days, and fibrotic phase occurs from 10 days onwards, about 10 for 24 days. The resolution also starts. It can go on for months together. This is typically what we learned in pathology. So stage of congestion, stage of red hepatization, stage of gray hepatization, red hepatization, and the stage of resolution. So molecular mechanism, it's because of the dysregulated inflammation, which is pathophysiological hallmark of ARDS. And pattern recognition, as I already said, it is important that pattern recognition receptors, such as toll-like receptors, which are highly expressed in the lung epithelium and alveoli. What happens is the lungs are basically never exposed to the what is in the blood, because that endothelial barrier is there. Because once the disruption occurs, all these pathogens, cell-injured derivative molecule, all sort of come into the alveoli and cause this problem. So alveolar dysfunction and edema formation, integrity of gas-blood barrier is maintained by tight junctional complexes in the alveolar epithelium and the capillary endothelium. These cells are connected by a protein complex called adherent junction. Injury to this complex are the major cause of expansion. Let's see this. You can see these are all we have what learned as a tight junction. You can see here between the cells, you have what is tight junction. This is the endothelium. Endothelium also has got this gap junction and tight junction, which is there. So here, because of this neutrophil action, and what happens is there is paracellular permeability. So what happens is the interstitial fluid sort of increases, the distance between these two increases. What happens is, because if you know, oxygen and carbon dioxide, they don't travel far. So as the gap between the alveolar epithelium and capillary endothelium increases, there is fluid there. So the exchange of oxygen and carbon dioxide also does not take place in a proper way. That's the reason why they can get hypo. Finally, coming to the mechanism of alveolar fluid clearance, the capacity of the membrane protein to effectively regulate alveolar fluid balance is reduced because of the epithelial damage which occurs. Exposure of the alveolar epithelium to hypoxia also inhibits the transepithelial sodium transport and decreases the overall alveolar fluid clearance. What happens is, as you know, the cells of the type 2 cells, the tubercle cells, they also have a mechanism of lung fluid clearance to the sodium pump. So this gets damaged. So whatever capacity they have to sort of clear this fluid goes up, so the fluid accumulates in them. So these are the newer insights. There's a lot of newer insights are coming into the what happens in the pulmonary edema. So these the this how this tight junctions are disrupted. What are the mechanism which is occurring and which is exciting. So what happens because of the surfactant? All of us know in newborn what happens. So what happens? This is, see, in the first picture, you see a alveoli which is collapsed. Here the surfactant is diminished. Say the surfactant is diminished. As per the Laplace law, the surface tension sort of depends upon the amount fluid or air which is there and into the radius. So what happens is if the surfactant is not there, then the compliance of the alveoli goes and sort of it loses its shape. When it loses its shape, because it is easier for alveoli to expand from an expanded shape rather than, that's the main basic of giving the P, keeping a higher P. So what happens is once it's already sort of lost its shape and atelectasis, to sort of expand, it really takes a large amount of pressure. So this is the one of the major problems what happens with the decreased surfactant. There is alteration in the lung capacity. What happens is here that edema reduces the compliance and end expiratory lung volume. The functional residual capacity, that is the amount of air which is there in the lungs after a normal exhalation, and you have what is called as the residual volume, which is after the forced expiration. There is also what is called as a closing volume. This closing volume should be always below the total lung capacity. But the alveoli, which has lost its compliance and shape and atelectasis, what happens is that functional residual capacity becomes lower than the closing volume. When that happens, it really needs a higher pressure to open this alveoli. This is what the physiology of it. So what happens in the gas exchange in acute lung injury or ARDS? In ARDS, what happens is there is fluid-filled alveoli. When there is fluid-filled alveoli with the low ventilation, perfusion units are there, because whatever it is, there is no gas exchange which is taking place. So alveolar over-distension in other area creates a dead space. So there are areas of normal alveoli, areas of fluid-filled alveoli. There is over-distended alveoli which is there because the ventilation perfusion mismatch is going to happen. Now, when if you give here 100% oxygen and you have the capillaries here, so wherever there is normal alveoli, the oxygen takes place. But half the oxygen goes to the other side, which is filled with fluid. So here there is no transport of oxygen into the capillaries. So this is so only about 50% you get. There may be a big over-distended dead space. There also it does not take place well. So this causes the intrapulmonary shunting, which is the dominant cause of arterial hypertension. This is basically the pathophysiology, but it is sort of a diverse because ARDS is caused by so many different type of pathology, like direct injury, indirect injury, maybe sepsis, all those things. With with this, I would like to summarize that ARDS is an inflammatory lung injury associated with the non-hemodynamic lung. It is not a cardiac edema. It is non-cardiac edema. Various pathophysiological mechanisms at play, as we know. It follows that different phases into the recovery stage. The activation of monocytes, which triggers the inflammatory response, leading to alveolar epithelium and capillary endothelium damage, is the hallmark, and it is the main cause what happens for the damage. And atelectasis gives rise to ventilatory perfusion mismatch, and there is all new insights into molecular biology and reveal a better understanding. Thank you so much.
Perfect. Thank you, Professor, for excellent session. I think you summarized it very well. Very difficult topic and very comprehensively covered everything. And with nice infographics and cartoons, which were quite self-explanatory. I think we are, I mean, we started late and we're running behind time. So, Professor Sohns, should do we have time for 2-3 questions, or you want us to take
later? Yeah, I just have to go and for the installation of our brand, I'll go and come back. That time we can, huh?
Okay, we'll do that. Thank you.
Okay.
Okay, I'm Heidi Flory. Am I waiting for somebody or?
Dr. Raju?
Yes, Dr. Heidi, just wait for your introduction. I think Dr. Rajiv will speak up.
Okay, thanks. Can you hear me on my headset okay?
Yes, we can hear you and you can see.
And can you see my slides okay?
Yeah, you need to click swap display because we are seeing the presenter view.
Presenter view, doctor.
Okay, presenter
Just
view.
click on the top, like swap displays.
Swap display.
Oh, right. Okay, better?
Now it's fine. Yeah.
Perfect, thank you.
Dr. Rajiv.
I can also introduce myself.
Yeah.
Okay.
Professor Iqbal will be introducing you. So Professor Iqbal Menon, if you can just introduce Professor Flori.
Hello.
Yes, doctor, we can hear you, please.
Yes, please.
Yes, doctor, we can hear you, doctor.
Okay, you want me to go ahead with me?
Yes, doctor, please.
Okay, because I didn't hear in between. It's a good evening here, and it's my immense pleasure to have an opportunity to listen to the experts here on ARDS and have the pleasure of introducing Dr. Flori, commonly termed Heidi, which is much easier to pronounce. And certainly a lady with a lot of distinctions. She trained, educated herself as an MD from East Coast, and then moved on with internship in New York to West Coast, and has a lot of board certification in PEDS as well as the PEDS critical care. Then she has a lot of academic, administrative, and other appointments, which have been really a kind of glorious and a heavy, lot of loaded career. She had a special interest in research has been for the acute respiratory distress syndrome, and she has really had a marvelous background, a lot of research, many grants, and I don't know where to stop, but I know that this should be good enough. Thank you very much for this opportunity. And Dr. Heidi, it's over to you.
Okay, thank you so much. Thank you so much.
Eddie, can I have a moment to introduce the moderator who just introduced you?
Oh, sure.
Just give me a minute.
Raji,
yes,
you were late. They told me to go ahead and I went ahead.
Iqbal, who is a very senior faculty, and he is the president of the Asia Pacific Pediatric Association called APA, and he's chairman, organizing committee, Asia Pacific Congress of Pediatrics. He has got a very checkered career and involved with various books and projects. He's council member of the Asian Pan-Pacific Society of Pediatric Gastroenterology. He's also standing committee member, International Society of Tropical Pediatrics. And he's head of department and professor of pediatric gastroenterology, hepatology and nutrition in Sir Syed College of Medical Sciences, Pakistan to date. And we welcome you, sir, as president to be with us and chair and be moderator for this session. Over to you, Heidi.
Thank you.
Okay, well, thank you again.
This is just the reverse order. It's okay. Sometimes you get kind of restoration before inflammation.
Oh yeah, absolutely. And it's pediatrics, so we have to be very flexible, right?
Right, exactly. Thank you.
Well, thank you so much for this great opportunity. And I'm really set up so terrifically by Dr. Soan's prior, because that was, and maybe we can get us on time, but maybe not. So with that, just to make sure I can advance my slides, here are my disclosures. My current disclosures actually relate to PARDS phenotype development, which are funded by the National Institute of Health right now. And I think since we learned about pathophysiology of ARDS and the history of ARDS with the prior two excellent talks, I wanted to take a step back, since we're focusing on biomarkers, to make sure everybody has a common framework for biomarkers. So the WHO more than 20 years ago identified a biomarker as not just a substance or structure, but it's something that does something important, right? It can influence or predict the incidence or outcome of disease. So just because you can measure it might be a good thing, but it needs to have a relevance. Likewise, within the US, the NIH and the Federal Drug Administration 6 years ago identified something similar, that it's a characteristic that can be an indication of regular biology or pathogenic biology, but it also needs to reflect a response to an intervention or a therapeutic intervention. So just because you can measure it is not necessarily enough. My good colleague, Dr. Carlton, and I here at University of Michigan have worked on some of this and wanted to come up with some caveats for what we think a good biomarker is. And so it should be potentially useful for prognostication or prediction of outcome, or useful in prediction of who could potentially benefit or be harmed by a certain therapy. But then some other a perfect biomarker would be available, which we cannot say of some of the biomarkers we've studied so far in PARDS, quick to assay, likewise potentially a problem, reliable, and reproducible, and easily interpretable, and hopefully, especially for pediatrics, as least invasive as possible. These graphs here just show you that these are a whole slew of common biomarkers of inflammatory markers, and you could see ranges are so different between serum measures and bronchoalveolar lavage measures. And so the dynamic range, this is a logarithmic scale, can even be worse for some of them and quite excessive for others, depending on your source of the markers. So these are important things, especially when we're talking about the lung. And the prior speaker, Dr. Soans, so elegantly showed both the histology and the pathophysiology in schema. And in applying what he described to us, which of these aspects of alveolar injury, interstitial injury, or vascular injury can we use as potential biomarkers? Another very important thing is, when is this patient coming to you? So what part of the phases of ARDS are you measuring these biomarkers? And as the prior speaker also described, we have an edematous phase, we have a hyaline membrane phase, and again, the hyaline membranes are not the same as the hyaline membranes in neonatal IRDS. These are hyaline membranes because the alveoli disrupt in ARDS, leaking protein into the space. The water can get reabsorbed, but the protein is left packing behind. And then a fibrotic phase, which maybe not every patient will have. So where in the course, is it prior to ARDS, early in ARDS, later in ARDS, are you to know which biomarker to measure? So to qualify a little more, we'll focus in this talk for the next few minutes on inflammation, alveolar epithelial injury, vascular endothelial injury, coagulation, and these PAMPs and DAMPs real briefly. So this is a great study from Europe that described by Dr. Schouten and Dr. Bosson and colleagues' labs about the also importance of the developmental impact that from neonate to pediatric to adult. Now, I know that's common to say kids are not just little adults. That may be a little bit too simplistic because they need to evolve into adults. So we need to keep this time spectrum in comparison. And you can see for certain markers, this is myeloperoxidase, this is ICAM, this is IL-6, this is P-selectin. There may be some differences over time. And there are differences compared to normal function versus in times of severe or other ARDS. In schema, in grand schema of early injury, early inflammation, and then later inflammation, this is work by Matt Zinter from UCSF in California, indicating that in early plasma samples within the first 24 hours of PARDS of 194 kids, you can really see a dramatic difference in the non-survivors versus survivors in the levels of each of these more common inflammatory markers. So these are all potential markers individually of prognosis. This is work, what I'll talk a lot about, expands on some of this, and is work from my colleagues, Dr. Mike Kwasny, one of my personal mentors for the last 30 years and a father of ARDS, Michael Mathey at UCSF, my current close collaborator, Mary Damer, and our colleague Anil Sapru at UCLA. Related to the ancillary work we were able to do on the RESTORE treatment trial, which the primary investigator for that was Martha Curley, currently from UPenn, related to ancillary study work we did to this acute respiratory failure study. So in this work, we really tried to see if we could identify patients who were going to have markers that could predict ARDS development. But what we found is that on the very first day of intubation, which is day 0 for acute respiratory failure, first of all, 80% of the patients who were going to have ARDS already had it, and 90% of patients who were going to have ARDS had it on day 1. And so we didn't do very well at predicting ARDS development because the vast majority already had it. We definitely saw, and this is logarithmic scale, that the vast amount of early inflammation occurs extremely early on in ARDS. And however, the marker does seem really nicely associated with PARDS versus no PARDS, and also with survival versus non-survival. And again, this is a logarithmic scale. And I wanted to point this out because this, I think, is a very fairly recent Egyptian study looking at SNP association of IL-1RA in community-acquired pneumonia. So which patients are potentially at highest risk of community-acquired pneumonia plus or minus ARDS development. And we did not find the same SNP in our work on IL-1RA, but I think more on this to come. And I wanted to toss this out there to the group because maybe some of those co-authors are on this talk right now. Going back to our work, we did the similar thing for IL-8, which is much later in the inflammatory cascade. And yes, again, we see vast increase, and this is again a log scale of IL-8 in patients who were non-survivors, very similar. And this is independent of severity of illness, all of these findings that I'm describing to you. We tried to match this then also with whether or not this inflammation can correlate with the presence or absence of bilateral disease on the X-ray, because we know the X-ray is always a conundrum in ARDS. And interestingly enough, the patients in this sub-study with bilateral infiltrates had a better clinical outcome, but we saw a logarithmic increase in IL-1RA across all days in these patients. We did not see the same in IL-8. So this is why this exists. With this, we're not 100% sure. Moving to alveolar repair. So as we talked about in the last slide, the AT2 cell is the progenitor. If they're all destroyed, they can hopefully populate AT1 cells, which might help you with fluid recovery, but then you still have a dearth of AT2 cells, so you have surfactant deficiency issues. And the jury's out. There's not that much in terms of biomarkers of early fibrosis. This is some unpublished work that we did 20 years ago, showing that precursors of fibrosis, procollagen peptide 3, on the very first day of ARDS was elevated in patients who died. So hopefully we'll be able to give you more information on this in the years to come. In terms of alveolar epithelial markers, we have SPD and we have RAGE in particular. I'll talk about that in a minute. This is work we did, again, trying to make sure always accounting for important covariates like age and severity of illness and disease associated with ARDS. And the severe PARDS patients, as expected, do have elevated SPD in the blood. And it also correlates with those who do not survive. RAGE, receptor for advanced glycation end products, is a really potentially really helpful marker of alveolar injury. This is expressed on AT1 cells, and you can see here it's really nicely, not exclusively found in the lung, but it's as highly specific, and blood is sometimes easier to get than BAL in a pediatric patient, especially one who is quite acutely sick with severe ARDS. This is Nader Yaya's work, who tried to compare Ang2, which angiopoietin is a vascular endothelial injury marker, together with RAGE. Again, very early on, this average specimen time was collected within 15 hours, and both these markers are associated highly with mortality. Interestingly, the vascular endothelial marker, as expected, would correlate more with vascular-related associated ARDS, such as sepsis, which is reflected in indirect population. But RAGE, which was the alveolar epithelial marker, was highly associated with direct lung injury in non-survivors versus survivors, but across the board, not as different as you would expect. Moving to the vascular endothelium, so we have selectins. This is again published by Al-Bitagi and colleagues again from Egypt, again showing and corroborating vascular injury highly associated with death, again, so prognostic markers. In the interest of time, I won't focus too much on the coagulation cascade, but thrombomodulin plays, as we know, an integral role in coagulation, but also in the inflammatory pathway response to sepsis. And we've seen this is Anil Sapru's work that and Ben Arwol's work out of UCSF and UCLA showing thrombomodulin in very early lung injury associated with mortality and multi-organ system dysfunction. PAMPs and DAMPs, again, this is just touching on everything in a 25-minute talk, and the prior speaker talked about this, so I'll save time by not doing that right now. But Nader did identify circulating nucleosomes, which are DAMPs, again, highly correlated very early on in pediatric ARDS with mortality. And soluble ICAM, which is a marker of macrophage activation, again, related to inflammatory process, but also a DAMP, describing, and this is again, this Egyptian group showing plasma ICAM much higher in the non-survivors for survivors, and actually corroborated work we did earlier in our group about 15 years ago. I think we will see in the next years more to come on neutrophil extracellular trap formation, or NETs, as different inflammatory processes. And 50%, as we know, of pediatric ARDS is related to acute infection, whether it's pneumonia or sepsis. But let's talk about other things that are highly relevant. And I think you want to hear a little bit about the phenotypes work. I think most people on this conference are aware of Carolyn Calfee's work from the adult ARDS, where she first described now 6 to 8 years ago in combining biomarkers and clinical risk factors into a latent class analysis, that two phenotypes exist, although the language for phenotype, subphenotype, and endotype is moving over the current discourse. But the hyperinflammatory phenotype differs dramatically from, for lack of a better term, hypoinflammatory, maybe normal inflammation phenotype. But this hyperinflammatory phenotype consistently over multiple assessments of multiple ARDS NET trials has a much higher mortality and worse outcome. Pratik Sinha, now from, I think, St. Louis, Missouri, but originally at UCSF, tried to make a parsimonious model with 3 or 4 markers. Why? Because again, based on the first slide, the optimal biomarker is measurable potentially with point of care and not just in a research lab. And using the most disparate markers in adults, found a really nice ROC curve with area under the curve of 94 and 95% in the parsimonious model. So with that, Dr. Damer and I used our work from the Bali cohort for identification of latent classes in pediatric patients. And we did notice, and I showed you the individual marker results for many of these work, highly variable levels in these patients within the first 48 hours of ARDS. So we thought maybe using this plasma, we could see whether kids differ from adults that much and if they had phenotypes. Our cohort had around 328 patients, and you can see the distribution of them, pretty sick cohort of patients again. And we did, lo and behold, I'll cut to the last patient pages of the mystery novel, that we also identified 2 classes. And when you mark them out, they look starkly similar to the adult phenotypes, with a hyperinflamed phenotype and a hypoinflamed phenotype. And we tried to match the LCA done in adults as exactly as possible. And Dr. Calfee and Kevin DeLucchi were mentors with this. What I think is extremely interesting is that, as we would expect, this hyperinflamed phenotype is more seen in the severe PARDS patients, but guess what? It is also evident in mild and moderate PARDS patients as well. And indeed, the hyperinflamed phenotype had longer duration on the ventilator and a higher mortality. We also tried to match exactly Dr. Sinha's work with a parsimonious model, and we also were really thrilled and surprised to find areas under the curve exactly similar to the work seen in adults, and hoping that we can take this forward to next steps for point of care testing. So this is our first work. We don't have a validation cohort yet. We're hoping to have a validation cohort with ancillary study to the current prospect trial, which I think that Dr. Knaber will allude to later on as well in his talk. To finish our talk, I think we'll mention the gene expression analyses, which I think will also be coming forward in our biomarker assessment of these inflamed and uninflamed phenotypes. This is work in adults with sepsis-related ARDS by Dr. Boss and colleagues again in Europe, also showing a reactive phenotype similar to a hyperinflamed phenotype, and showing enriched oxidative phosphorylation, not unexpected mitochondrial cell dysfunction, and gene expression patterns related to macrophage activation. Moving back to pediatrics, because this is a pediatric ARDS seminar, Nader tried to look at PARDS subphenotypes with RNA expression patterns as well, and identified 3 cohorts, not 2, which you can see defined here. And again, these are measured within 24 hours of PARDS onset, and certainly there's a different outcome measure for each of these PARDS categories. So this is all exploratory work. This is all in the research lab, but there's definitely going to be more to come. This is a small study related to gene expression in patients who ultimately ended up, some of them ended up on ECMO and needed advanced life support. And again, different subphenotypes being identified, and certainly the sickest of the sick who ended on ECMO definitely had a different gene expression pattern than those with MODS, no ECMO, and those of controls. One of our colleagues here at U of M, Rodney Daniels, is also looking at biomarkers related to reduction oxidation potential, and this may be particularly useful if we're starting to use antioxidant therapies in the future, like N-acetylcysteine or vitamin C, that we can potentially look at redox potential in real time to see if we can get response, use redox potential as good or bad response to our antioxidant therapies. And finally, Jocelyn Grunwell, currently at Emory in Atlanta, very recently, this is actually just a couple months old, looked at a very easy to measure airway fluid metabolites. So again, this hits a good feature for a good biomarker. For pediatric acute hypoxemic respiratory failure, although 55% of her 74 patients ended up with pediatric ARDS, also identifying 3 clusters of patients that have much different time on the ventilator in terms of ventilator-free days related to different metabolic pathways. And so in her work, and in this case, it's ventilator-free days. So ventilator-free days are the number of days that the patient is alive and off mechanical ventilation in a 28-day month. So higher is better. And so in her groups, we see all of these alanine pathways, citrulline, homoserine, methionine, and threonine pathways, much different association of outcome in these exhale breath condensates in these pediatric patients, and across a significant difference of PARDS severity of illness. So this is another potential really exciting opportunity in the future. So the goal of this is to use this in clinical trials to predict which patients would be the best to trial in the randomized control trial, and which you don't want to include in the trial because they may be harmed. This is the whole focus of precision medicine. And I think also we want to track the biomarker trajectory over time so that you can then further tailor the treatments and the diagnostics for each patient individually. And so the holy grail for this is to do this in real time. This is again work by my colleague Erin Carlton from University of Michigan to try to establish point of care testing using microfluidics models, which are still not ready for prime time, but this would get you your inflammatory markers potentially within a 4-hour turnaround time. And Danny McCauley is currently starting a observational point of care study in ARDS, which will be prospective identification of these patients. It's called the FIND study. And this is going to take the markers found in all of those ARDS net predictive enrichment studies that Dr. Calfee did with the 2 phenotype group. And those were all retrospective analyses. And he's going to try to identify the similar patients and in a point of care fashion, do those same markers in real time and see if, again, in a prospective fashion, it correlates with outcomes. And then the next step from there would potentially be to use that technology in actual RCT identification of patients. And so with that, I think we may now be a little bit more close on time. And it always takes a village to do this kind of work. And this has been my village over the last 25 years of this work. And hopefully I can answer some questions, particularly at the end. And thank you very much. I will try to unshare my screen. Did that successfully unshare my screen?
Yes, doctor.
Taufik, can you hear me?
Yes, doctor.
Okay. We'll leave any questions to Dr. Flory. Dr. Iqbal, any questions to Dr. Flory? Dr. Iqbal, any questions to Dr. Flory?
Well, I think we have decided that the questions will be at the end of those sessions.
Okay, fine. Okay. We'll stick to that. We'll stick to that.
Yeah, thank you.
I will. Shall I go ahead to introduce the next moderator?
Yeah, please do.
Please put the video on. Can you hear me? Hello.
Yes, doctor. Please go ahead.
Yeah. So I have great pleasure to introduce my colleague, Dr. Praveen Kumar, who is the head of Department of Neonatology in Postgraduate Institute of in Chandigarh. It's a pioneering, I think the most pioneering academic institution of India. He's done a lot of work on pediatric and newborn areas with special interest in retinopathy of prematurity, hyperbilirubinemia, and ventilatory care. He has been my colleague for almost 3 decades, and he has published numerous peer-reviewed papers and books. And he's a teacher of teachers. In fact, one of our moderators is a student, Dr. Sridhar. He's now he's going to take over as president of the National Neonatology Forum by next year, and which is a body comprising of almost 15,000 neonatologists. Over to you, Praveen. Welcome to this seminar. Good evening.
Thank you. Thank you, Rajiv. Thank you. And a very good evening to everyone. And my congratulations. My congratulations to you, Rajiv, as well as Sridhar and the IAP Neonatal Chapter of, for really taking up this academic work with great enthusiasm and regularly organizing great symposiums like these ones. And of course, we are very fond of your book, Rajiv. So Dr. Peter has been introduced to you already by Sridhar, but I will just like to re-emphasize. Peter has been, a kind of the boss of neonatal and pediatric ventilation. And I remember Peter visiting India in one of his several visits, including to my institute, PGI Chandigarh, for conducting several workshops on pediatric and neonatal mechanical ventilation. And I think, again, Peter's book is the most famous one about pediatric and neonatal ventilation. And I was fortunate to have contributed something to that book also. And as we see from his biodata, Peter has been very well accomplished researcher, academician, and is an editor of several important journals, including Pediatric Research. He has been an executive committee of the European Society of Pediatric and Neonatal Intensive Care Medicine and has been its past president. In 2021, he was recognized for his lifetime achievement with Dennis De Victor Award from the European Society of Pediatric and Neonatal Intensive Care. And Peter is going to tell us about the most fundamental, modality to treat ARDS, because unless we do this well, all other modalities are not going to work. So over to you, Peter, for his talk on optimizing conventional ventilation and recruiting the lung. Peter, all over to you.
Thank you, Dr. Praveen. So I just share my screen. Hope it looks fine.
Yeah, it's all visible.
That's today's situation in Geneva. Beautiful weather, sunshine in the afternoon. So I was asked to talk about optimizing mechanical ventilation in parts, including lung recruitment concepts. I have no conflict of interest to declare in relation to this presentation. So what are the unknowns in pediatric mechanical ventilation? Some year ago, I did a paper about this on invitation of intensive care medicine, and we sorted out that several things are not so clear as they seem to be in the adult world, or perhaps in the neonatal world. So what are the lung protective strategies? Small tidal volume ventilation and or pressure limitation. So is it correct to use tidal volumes per kilogram, pressure limitation, limiting discharging pressure as a concept? And the other important concept is positive and expiratory pressures and lung recruitment strategies. So what about PEEP? What about recruitment concepts? So small tidal volume and higher PEEP. Everybody is defending this nowadays, as nicely summarized in this graphic by Martin Tobin, where he showed just when you use large tidals, low PEEP, as said before, you run the risk of atelectasis or overdistension stretch injury. So common concepts nowadays are optimized mechanical ventilation. That's what we all say. So we say use tidals 5 to 8 ml per kilogram, use a limit plateau pressure below 28, and use higher PEEP. And then the big question about recruitment. I come back on the small tidal volume ventilation ARDS network trial, 6 versus 12 meter per kilo. Just to remind you that there was also in the two groups a big difference in inspiratory pressures, or the peak pressures or the plateau pressures, not only the 6 ml per kilo that perform better. So you could say it's perhaps could be the pressures. And there was also the effect relatively small, because only 1 out of 14 patients had a benefit when 6 ml per kilo were used instead of 12 ml per kilogram. But what about 5 to 6 ml per kilogram in the pediatric population? There's Martin Kneiber's group, is the Jager, who could show by analyzing all the pediatric published data at this time, most of them retrospective studies, that there is no relationship between tidal volume mortality in children, as you can see for different subgroups, 7 versus 10, below 7 versus 12, below 8 versus above 10, below 8 above 12 ml per kilo, no difference in outcome between the two strategies. Furthermore, and I just take this paper, there are other ones out, but just a paper from Samuel Eriksson, who showed an inverse relationship between tidal volume ranges, so median tidal volumes, and outcome. So the higher the tidal volume, the better the outcome, as you can see here, with a OR ratio below 0.8. Whereas it could show that inspiratory pressures were directly related to outcome, so higher inspiratory pressures, worse outcome, as the OR ratio shows, with a value above 1. So we could interpret this that the pre-existing degree of sickness relates to mortality too, as I tried to show in my keynote lecture as well. So in patients with less compliant lungs, high pressure resulted in small tidal volumes. This is interpretation what you observe here. So the patient that had 31, so the pressure limits, high pressure limits, was the one that actually ended up with small tidal volumes because the physicians did not allow for higher plateau pressure. So there were very sick patients, high pressures, low tidal volumes, versus less sick patients had larger tidal and did reach with this only low pressures. then means that we have in the lung-protective ventilation, we have small evidence about the importance of a specific tidal volume as being protective. And we have even observed this inverse relationship in some studies. It was another one from Los Angeles as well. So let's go back and think about the basic pathophysiology of hypoxia respiratory failure. So it's a restrictive lung disease. Restrictive means that we have a reduced FRC, so this function is a capacity. Patients that have a restrictive lung disease, they reduce the tidal volumes spontaneously and increase the rate. That's what we do. We get an infection and pneumonia like this, we get tachypnea and reduce our tidal volumes. As a physiologic concept behind and response, we will have an increase pulmonary shunt, is resulting in hypoxemia, and an increase in alveolar dead space, resulting in hypercapnia. And this describes the hallmark symptoms of ARDS, of restrictive lung disease of various origin. And this brings us back to the physiology, the baby lung, as I mentioned this before. So in restrictive lung disease, in inflammatory restrictive lung disease, the ARDS lung is small. So this was coined, this term, by the adults, where they looked into ARDS patients. They measured the areable remaining tidal volume in these lungs, and it was correlating to the age or the size of a lung of a 5 to 6 year old boy child with a normal lung. And this, for an adult, is the baby. So it's the small lung in the big body. And this was correlating, this residual inflated lung volume was directly correlating to the compliance measured in these patients. So the compliance is an indirect measure of this baby lung compound, so the percentage of the expected normal lung volume. And this brought us early on already the concept that the ARDS lung is rather small and stiff. So our tidal volume per body weight ratio does not make big sense because it does not take into account the severity or the expression of lung disease in terms of reduced residual inflatable lung volume. So this term or this way is probably not the best way because we should correlate it to the baby lung ratio or tidal volume. So the smaller the residual volume, the smaller the allowable tidal volume in these patients. And this brings us to the concept of strain in ventilator-induced lung injury. So the change in length in relation to the initial length, which means the tidal volume that we apply in relation to the volume at end expiration, which is FRC plus the peak volume. As FRC is reduced and the people we try to compensate partially for the reduced FRC, you have to be careful in severely reduced, patients severely reduced FRC about what tidal volume size we're going to use. And this brings us back to this situation. So in the normal lung, where we have a normal FRC, allowable tidal volumes can be quite big without we having the risk that we overdistend these lungs. Whereas in the sick lung, the lung with a low FRC, there is a higher risk that even with small tidal volumes, we can overdistend the lungs. So in this condition, we have a low strain condition. Here, you're at high risk for a high strain condition, which means high risk for inducing further injury. This has been taken account in the PALH recommendations about what you should do with tidal volumes. We said at this time, tidal volumes need to be adjusted according to disease severity. So it's not to body weight as an only term, it's disease severity. So we say 3 to 6 meters per kilogram for patients with poor respiratory system compliance and closer to physiologic range, 5 to 8 for patients better preserved respiratory system compliance. And the new upcoming recommendation that will probably come out this year, we stay more or less on the same recommendations. And this brings us to my approach to a patient. So my first ventilator settings. If I have a patient post-operative care with a normal lung, I assume that his compliance, the respiratory system compliance, is more or less normal. Let's say 0.8 to 0.9 centimeters water per kilogram. So if I take according to recommendations now 6 to 8 mil per kilo, I will need about 7 to 10 centimeters of a driving pressure, distending pressure above PEEP. I add a low PEEP to start with, and I will end up with an inspiratory pressure about 12 to 15. As I use normal tidal volumes, normal respiratory rates will allow for normal minute ventilation and consequently normal CO2 washout. However, if I have a patient with hypoxic respiratory failure, infant respiratory syndrome, pediatric ARDS, in terms of mechanics, they're the same, congenital diaphragmatic hernia, I assume that they may have a reduced compliance, and this I assume according with the oxygenation deficit. So let's talk here about reduced compliance by 60%. So about 4.4 to 0.5 ml per centimeters of water. So I know the residual aerable lung volume is small. So I start with smaller tidals, 4 to 5 ml per kilogram, and we'll observe what I need to achieve this tidal volume in terms of driving pressure, distending pressure, and you will end up with this kind of compliance around 10 to 13 centimeters of water, plus underlying PEEP of minimum PEEP of 5 centimeters. I will end up with inspiratory pressure around 15 to 18. So you see that you're in front of a patient that has already 25 centimeters of inspiratory pressure. Maybe you do something wrong in your settings, or he has a very, very poor compliance. As I use smaller tidal volumes, I will increase the respiratory rate to compensate for CO2 washout to have normal minute ventilation. And it's only then, and I think, to start about oxygenation, improvement, and PEEP. And I think this is a safe approach, starting first with what we do in distension to the lungs before we think about how we can improve oxygenation. Remember, oxygenation or hypoxemia is not killing the patient. And this brings us to the Prato pressure limitation. The recommendations are 28 centimeters of water, slightly higher if you have poor chest wall elastance, because this is compressing against the extension. So 29 to 33, the recommendations. To explain what we mean with this, what do airway pressures mean? So if I apply a plateau pressure of 25 centimeters, my transpulmonary distending pressure, the one that is creating the lung volume at end inspiration, will be 25 if my intrathoracic pressure is 0. So this is the condition of the paralyzed non-active patient. If my patient has a severe chest wall edema or abdominal dyspnea, abdominal distension, there's a counter pressure which will increase the intrathoracic pressure, let's say to 10 centimeters of water. My 25 centimeters that I apply will end up, therefore, in a transpulmonary pressure of 15, so 25 minus 10, of transpulmonary pressure to 15. So despite applying 25 centimeters of water, my lung volume at end inspiration will be much smaller than in this condition. So we have to keep this in mind. What we do outside does not tell us exactly what's happening in terms of transpulmonary pressure inside. And this brings us to the concept of distending pressure, as I mentioned already before. So this study by Amato, taking back the data from several ARDS adult network trials, actually was showing then when the distending pressure, the pressure above PEEP, was more than 15 centimeters of water, there was a clear increase in mortality compared to predicted outcome of mortality. And if you can see here, if you take these ranges of distending pressures from about 8 to up to 33, you can see here that tidal volumes these patients saw with this kind of distending pressures are overlapping. So the tidal volumes do not give us a real good indication about what we should do in a patient. And distending pressure indirectly gives us a safety approach, because in the severely ill patient with poor respiratory system compliance, if I use a distending pressure of 15, my tidal volumes will be smaller automatically than in a patient with a good respiratory system compliance if I apply the same staining pressure. However, I do not say that you have to use 15 centimeters of water staining pressure. If you can keep below and still ventilate the patient, keep it below this magic number. This has been compared and confirmed in the lung-safe study in the adults, where they could show that the driving pressure in this range above 15 was actually associated with higher mortality. Plateau pressures above 30 associated with higher mortality, and peak and speed pressures above 35 associated with higher mortality. So, first part conclusion, optimal tidal volumes. The term volume does not primarily refer to the concept of tidal volume, but to the ratio of tidal volume versus residual functional lung volume. So the sicker, the smaller the lung, the smaller tidal volumes are allowed. And in this pressure limitation, as we use many of us, pressure control ventilation allow for automatic dynamic tidal volume adjustments by the ventilator, because the pressure effect will be depending on compliance. Tidal volume targeting, as it becomes more common again, certainly in the neonatal field, might be preferable in some patients, some populations, when you want to really assure the risk of hypocapnia or the risk of going into hypercapnia in these patients. But again, this would be a second step once you sorted out the appropriate tidal volume for this patient in his today's condition. So in any case, tidal volumes greater than physiologic tidal volumes, that are about 6 to 8 milliliters per kilo, in normal subjects should never be allowed. So what do we know about PEEP levels? PEEP levels, the recommendation, and I did not like them too much at this time. Moderately elevated PEEP levels 10 to 15 according to observed oxygenation and hemodynamic response. So you have to turn up somewhere your PEEP and see what the hemodynamic response and oxygen response is. Certainly want to avoid hemodynamic problems when you increase PEEP. And we said also at this time, as a compromise, PEEP levels greater than 15 might be needed for severe ARDS. Also, attention should be paid on meeting the plateau pressure. Because if you have 50 or 18 centimeters of water of PEEP and you add on top 15 centimeters of descending pressure, you will overdo allowed plateau pressures. So what does mean provide enough PEEP? It would provide enough PEEP means to recruit the recruitable alveoli, while at the same time not applying so much PEEP that healthy regions are unnecessarily over-distended. So if you have in this ARDS lung, we do incremental PEEPs, we may reduce antitidal alveolar collapse and opening, because we're going to have an effect on the aerable and recruitable lung volume. So here we could recruit some lung volume. But there is a risk that in the normal aerated area with high PEEP, we're going to cause lung hyperinflation. And it's actually a fact that the ARDS network trial, who trialed 6 versus 12 meters per kilo, did not only look at tidal volumes, he had also a PEEP titration scheme in it. So according to the FiO2 needed, PEEP had to be dialed in, and you can see in very severe hypoxemia requiring high oxygen concentrations, very high PEEP levels were used. So we have to be a little bit careful to say it's only tidal volume that made the difference. It's highly likely that the PEEP titration scheme had effect on outcome as well. And this is somewhere confirmed by this meta-analysis by Brill, who looked into the time to death in hospital for higher and low PEEP levels stratified by prevalence of ARDS at baseline. And you can see here in patients with ARDS, higher PEEP levels were associated with better outcome than lower PEEP levels. Whereas in patients without ARDS, this association could not be shown. And what do we know from the pediatric field? We have no real randomized controlled trials or meta-analysis, high versus low PEEP. But I think we have a very important study from Robin Kemani's group in Los Angeles, where they did a multi-center retrospective analysis of patients with pediatric ARDS, and they were looking in these patients if they received a PEEP level above the recommended PF ratio concept of the adult ARDS trial, the one I showed you before, or whether this PEEP was below this recommendation. And you can see for all patients, when on protocols, the high PEEP group, which means at least as much PEEP as recommended by the ARDS network trial or above, was resulting clearly in a better, much better outcome than using too low PEEP levels. And this was the most marked for this, the moderate ARDS group. So we can say nowadays that keeping or using PEEP levels at the level or slightly above what the PF ratio scheme from the ARDS network trial was recommending seems to be an important protective ventilation strategy for pediatric ARDS and should be used as a first step in any unit. And this brings us to the question of recruitment and the question we should ask us in front of an ARDS patient: how is his lung functioning? Usually we have three components. We have diseased lung, non-recruitable, we have the diseased lung recruitable, and we have some normal lung areas. So there is a risk as soon as I increase PEEP that I may overdistend some area, create dead space. It's the risk of baro and volar traumatism. On the other hand, if my PEEP is too low, I have the risk of shunt, intrapulmonary shunt, zone of atelectasis, and atelector trauma. So this is the reason that we recommend to use recruitant approaches, which means with small tidal volume, least distending pressure as possible to achieve with the respirate and combination of tidal volume respirate reasonable CO2 to titrate PEEP slowly up in front of a patient with severe hypoxemia, testing out if he can recruit or not, if there is improvement in oxygenation. So this means you increase in small delta pressure, small tidal volume, slowly your PEEP by steps up and down again. You should observe when the patient is recruiting that at some level, maybe much higher only, that he starts to improve oxygenation without that you create more dead space, means without that you overdistend, and this can be sorted out usually by CO2 measures online. And make sure that you do not run hemodynamic compromise. This approach has been used here in adult patients with ARDS, looking at oxygenation, at dynamic compliance, shunt fraction, and the amount of non-aerated tissue. They slowly went up to a high level of PEEP, and then from here they come slowly down with the PEEP level, keeping the delta pressure the same. And you can see that when going up or when coming down, oxygenation was initially very high. At a certain point, it starts to drop again, so collapse is starting to happen. Shunt is coming back, as you can see here, and you can see that the CT non-aerated tissue percentage value is increasing. A good indicator where this actually happens is the compliance. So dynamic compliance going and improving when going up, sliding off because you're overdistending here, and then when coming back, getting a very high increase of dynamic compliance before collapse starts to happen, where it starts to drop again. So looking at bedside during recruitment maneuver, small steps at dynamic compliance, oxygenation, and CO2 is a good mean to work this out. What do we know from recruitment maneuvers? Again, pediatric data is sparse. We have some meta-analysis from recruitment maneuvers for adults, and you can see that the studies showed in general a slight benefit with risk ratios between 0.8, 0.8, 0.8, and 1 here. So this one showed no real benefit, but the other showed just a borderline or a real benefit. But the quality of evidence is relatively low because most of the studies included other co-intervention at the same time. So it's really hard to conclude nowadays It's only the effect of recruitment that had an effect on outcome. However, Kaczmarek study here, a really nice study that used this open lung approach concept, going up, going down to find the best place before oxygenation started to drop and compliance started to drop, showed much better outcome for patients submitted to this recruitment approach with an open lung approach compared to control that were not recruited at all. So PEEP levels, as said before, you can deal around with some numbers. Nowadays, we recommend to use, if you do not do formal recruit maneuvers, to use the ARDS network PEEP FiO2 scheme, which is in fact some kind of indirect recruit effect. The more oxygen you need, the higher the PEEP. And recruit maneuvers can be attempted, but you have to be careful, do it slow and incremental and decremental PEEP steps. Do not know sustained inflation. Do not use sustained inflation, because these are highly risky, because you do not know how high you have to go up and come down. So the question is now the combination. Again, tidal volumes and PEEP combination bring us back on the strain. So we have to think about the tidal volume and the effect of PEEP in terms of creating inflatable lung volume for gas exchange above FRC. So again, this discussion, tidal volumes smaller if you have a sick lung with a low compliance, with a low FRC, with poor oxygenation, larger tidal volumes if you have a more normal lung, higher PEEP used if you need a lot of oxygenation according to PF ratio scheme from the ARDS network trials, lower PEEP used if you have better oxygenation according, again, the PEEP FiO2 ratio from the ARDS network. And if you take this concept of strain on the study from the adults, from Amato, where he was showing when you keep PEEP stable in patient, you increase your delta pressure above, the higher the delta pressure, the higher the risk for mortality. If they kept the plateau pressure stable and increased stepwise PEEP, so different groups with higher or smaller PEEPs, the higher the mortality when low PEEP are used, there was big descending pressures, the lower the mortality with high PEEP and lower descending pressure on top, independent of the plateau pressure, as it was here, independent of the PEEP pressure. And he worked then out, then if you increase your PEEP, so you compare patients with lower or higher PEEP, up top, always the same limiting descending pressure of 15, there is no effect on outcome in any combination as you keep descending pressure stable. So this brings us back that descending pressure is an important parameter nowadays, and there are upcoming studies from the pediatric field, several of them now under submission and in publication, in preparing for publication, that show the same effects in the pediatric population. Brings us back to the LungSafe study, driving pressure, the most important factor that has an influence or is associated with outcome in adult ARDS. So here, certainly for moderate to severe ARDS. PEEP has an effect in some populations, some groups, severity grading. The plateau pressure has an effect in severe ARDS, whereas once more, the tidal volume shows no association to outcome at the end. So the best recommendation nowadays, what can we say? Protective ventilator strategies provide enough PEEP to recruit the recruitable alveoli. I think this is the important part, and you have to give your means at bedside to understand what's happening to this lung. Do I have an effect on oxygenation? I'm sure I do not have hemodynamic compromise. I am sure that I do not overdistend, and to recognize overdistension, best is to do continuous CO2 monitoring, because it will respond to the increase of dead space that you create when you overdistend the lung. Avoid a PEEP tidal volume combination that unnecessarily overdistends the lung regions. So if you use very high PEEP, be very careful with tidal volumes on top. And again, here, the distending pressure may help to give you some security on the tidal volume combination, limit your inspiratory pressure, plateau pressure to 28 to 30 centimeters of water, and limit your distending pressures. Go about in every situation, if a normal or a sick lung, more than 50 centimeters of water. In the sick lung, 50 centimeters of water will result in smaller tidal volumes, and you may, in a very sick lung, allow for very small tidal volumes to 3 to 4 milliliters per kilogram if it's necessary. So the concepts of lung protection is polytrauma, avoiding polytrauma or overdistension, avoiding collapse, trying to limit the volumes in terms of tidal volumes, and trying to limit the distending pressures. Because you have a lower limit given by the PEEP, you have an upper limit given by the plateau pressure, and the safe range is in here with limiting distending pressures, and in result of this, tidal volumes will be limited within the acceptable volume range. So there's few other questions that come up nowadays, and they're still unknown. What about maintaining spontaneous breathing versus using neuromuscular blockade? And if you look at the data in the pediatric areas, we have no proven data at the moment that neuromuscular is reasonable. And the question is, does it improve outcome? We are waiting eagerly the study from the Martin Kneiber's group on neuromuscular blockade in children with ARDS. Based on the adult, there is some signs that there might be a benefit for specific conditions. Big questions about patient ventilator synchronization. We always say optimize patient ventilator synchronization will improve outcome, but in fact, so far we do not have real good data to confirm this hypothesis. Then about the level of support, including proportional assist, should improve outcome. We do not have data yet in the pediatric field. So what about maintaining spontaneous breathing? The problem is distribution of aeration in the lungs, so the question between VAQ mismatch. With spontaneous breathing, as we have a diaphragm that pulls down, and this pulls down because of the shape mainly on the dorsal part of the diaphragm, we will improve ventilation perfusion relationship in this distal area, those who are prone to collapse most. Whereas without spontaneous breathing, the air goes mainly in the ventral parts, the anterior parts, because there is no diaphragm activity, because we push the diaphragm only down on this side, which means worsening of VAQ. This is the concept of maintaining spontaneous breathing. I can see here, without spontaneous breathing, the same patient, when he starts a spontaneous breath at same ventilator setting, how much better he recruits this area by his own respiratory efforts, by his active diaphragm. So on the other hand, the active patient has become now a problem, or we consider that we have to be careful because we learned about patient self-inflicted lung injury in the patient in whom we assist his spontaneous breathing. Again, I come back to this schematic drawing. In the passive patient, a plateau pressure of 22, a PEEP of 8 will have a certain volume effect. So the transpulmonary plateau pressure in this paralyzed patient will be 22. The transpulmonary distending pressure will be 14. Whereas when the patient takes big respiratory efforts, he will create a negative interthoracic pressure, and this will lead with the same settings to a plateau pressure, transpulmonary plateau pressure is clearly above 22, and a transpulmonary distending pressure, which is clearly above 14. So that's one of the recommendations. Also, if you are in non-invasive ventilation, where ARDS is worsening, not to delay too long intubation and keep control on sedation and paralyzing these patients to avoid this big pressure, transparent pressure swing in the spontaneous breathing patient. These big pressure swings, as measured here with esophageal pressure and ventilated pressure, are the ones that we are fear of. So the swings in the transient pressure will have an effect on lung stress, causing the inflation of big volumes. And you observe in these patients, you set a certain pressure setting, he starts breathing, and all of a sudden his tidal volume is much bigger. Be careful with tidal volumes that you read above physiologic tidal volumes. So go certainly not about, do not allow for more than 12 milliliters per kilo in a sick patient with spontaneous efforts, because this may be not a good sign. The patient might inflict by himself further lung injury. And this again to explain the problem, in the pressure support mode here, this patient, he takes T-beep, esophageal pressure by inspiration. So the difference that actually comes to the patient as a transpulmonary pressure is the combination of the assisted breath level and the effect or the force that the patient creates himself. So be careful, do not allow for vigorous spontaneous breathing, do not allow for large tidal volume in these patients, because you may further increase your lung injury. And this brings us, and I come to the end, the concept of the adult patient in severe ARDS with a PF ratio below 150. They use neuromuscular blockade for the first 48 hours. PEEP settings, relative high according oxygenation exchange, according to PF ratio table, tidal 6 to 8, and could show when using neuromuscular blockade for the first 48 hours, instead of assisting ventilation, was allowing for improved survival. Just one last word about the concept of permissive hypoxemia. We tend to say, well, this patient is very sick, which might be permissive and allow for lower oxygenation and just try to stand out the problem. However, we have to remind ourselves that in hypoxemia, there is a hypoxic respiratory drive. So the patient will increase his respiratory drive, and this will lead again to higher pressure swings if he's on spontaneous breathing. So you can see here in a low FiO2, so saturation target only of a permissive target of 85 to 90%, low oxygen, the patient increases respiratory rate, increases his spontaneous invert and his PO1. So the patient does more work. This will lead again to the risk of self-inflicted lung injury. So permissive, be careful in a spontaneous breathing patient. So this means when we take the PEMVEC recommendation published by Martin Kneiber and a group from ESMID respiratory section, we have to think about disease severity in restrictive disease, mild, moderate, severe, the classical severity degrading for ARDS, to which point we might eventually use high-flow nasal cannula, poor data if it's not for some bronchiolitis patient at the moment, CPAP, to which level CPAP or non-invasive ventilation, be careful not to go higher and not to use it in severe patients. Should we target lower tidal volumes than the 6 ml per kilogram? I think yes, certainly in the severe ARDS patients, and this tidal volume will partially be dictated by our pressure, the driving pressure limitation. Target value seems to be about 14, 15 for the pediatric patient, like for the adult as a maximal value, not as a target value, sorry. Higher PEEP, we recommend nowadays to use as a first attempt the PEEP FiO2 ratio from the ARDS network trial. Consider lung recruitment to sorting out if there is still some recruitable lung tissue. If this is the case, this should allow you to reduce the FiO2, and the consequence, according the PF ratio scheme, your PEEP in the second part. Where's the point of high frequency oscillation? Martin Kneiber talked about, and extracorporeal life support. Thank you very much for your attention.
Thank you, Dr. Peter. I think, as usual, it has been a wonderful blend of physiology and evidence, and trying to build up the case, the why particular recommendations are there. I think that makes it self-explanatory for everyone, and so it is a wonderful talk. And I think there are several lessons which come out of it, because what Peter showed, ARDS is a syndrome, so you can't treat with same numbers each and every lung. And what he told us, in case the container itself is so stiff, you obviously have to ventilate with lower tidal volumes rather than trying to injure the lung. But if the lung is a normal compliance, then you target higher tidal volumes. And you introduced us to the concept of strain rather than only relying on tidal volume or PEEP as a marker of potential volume trauma or lung injury. And then Peter also highlighted the concept of self-inflicted lung injury by the patient. So which means we don't have to be afraid of intubation if required, and intervene at the right time. And of course, it's all easy to say, but it's an art and one has to learn over time. So thank you for that wonderful illustration, Dr. Peter, once again. And if Dr. Rajiv and Sridhar allow, maybe we can take up the question addressed to Peter straight away. I think there's some in the question and answer box. I can see Peter has already addressed many of them by replying, but there may be some more which he could address verbally. Is it okay, Dr. Sridhar?
Yes, sir. Yeah.
Peter, this side breath, it's a very controversial thing about side breath. Side breath in the treatment of ARDS.
About?
The side breaths, you give lung recruitment strategies.
As I said, we cannot recommend side breaths because you do not know which pressure level is needed to recruit. And if you use side breaths, it's depending on your definition. Is it 30 centimeters for 30 seconds, 40 centimeters for 40 seconds, or whatever you see from the adult population? The risk is that if you go up to a certain level of side during a certain time, you may cause severe overdistension, or you may not have an effect at all. If you cause severe overdistension, you run the risk of hemodynamic compromise and problems. So the only way we consider, and it's also the Polish group in the new recommendations, if you do recruitment, go by small steps, use relatively small tidal volumes. You may even below recommendations. You excuse me, reduce small delta pressures or distending pressures to avoid any risk that you run in overdistension. So side breaths we cannot recommend, and in my opinion, I said this for many, many years, you should never use them.
Thank you, Dr. Peter.
Thank you. So there's a question by Dr. Subhasini, Peter, about airway pressure release ventilation. Is there any role in pediatric ARDS, and could it worsen the patient-induced, self-induced lung injury as you were mentioning?
Well, there is no solid data on APRV in the pediatric field. We have no controlled trials, so at the moment we have no evidence of the benefit of it. And it's depending how you set your settings, APRV, but since you let drop the pressure from time to time, depends where the patient is in his respiratory phase, it may have also at this moment, we may receive a very large tidal volume, as might happen the other way around if you use side, for example. So we have no data at the moment to recommend, but we need urgently studies.
Thank you, thank you. And then there's a question about the role of transpulmonary pressure monitoring. What is the role of transpulmonary pressure monitoring?
Well, optimal, we should measure transpulmonary pressure. There are two issues. If you use independent devices, the problem is that you have these esophageal manometers, which are classically the balloon manometers. You have not stable readings. So it's crucial to inflate your balloon to the 0.1 milliliter exactly, otherwise you get completely wrong measures. This has been shown by us, and actually it was a very nice publication on this by Christopher News a few years ago from Los Angeles. So we do not have the real good tools. A way around this, if you have a ventilator that has transplant pressure monitoring, so esophageal pressure monitoring with a kind of bicore device behind, that inflates at each measurement exactly balloon to the same volume, then you may get relatively good measures. But this is only feasible with fully integrated devices and not the classical way we would do it by side insuflating with a syringe. So at the moment, we are stuck there, and the smaller the child is, the problem comes then much more. Do I add to the gastro-feeding tube another one? But it's a problem. And a big request from us to the industry is, and I take the chance of opportunity to mention this, when you have for the Nava sondes, where you have actually feeding tube and electrodes on one sonde, we would highly likely to have there also a reliable esophageal pressure measurement. But for the moment, for technical reasons, they cannot manage it in this small size.
Thank you, Peter. And there's another question by Dr. Gayatri. Is there any role of diuretics in ARDS?
I think the data from the adults, again, based on data from adults, there's a role of diuretics. There's certainly a role to not fluid overload patients. So there's a clear association between restricting fluid and outcome in adult ARDS, independent on the ventilator settings they use. So it's a very strong signal there. Again, in pediatrics, we do not have real good studies about this. So I think my role is in an intubated patient, you have a reduced insensible loss of fluid because you do not evaporate. We do humidificate the system. So reduce your basic income in an intubation patient already by 20 to 40% of normal intake. And then you don't run into the problem that you really need diuretics. But in the early phase, in the inflammatory edema phase, it might help a little bit.
Thank you, Peter. And there's some questions I think they are going to be addressed in the subsequent talks about surfactant and all. So thank you again. This was a really wonderful session, and I would hand over to the organizers, Dr. Sridhar and Dr. Rajiv, for the subsequent proceedings. Thank you very much.
Thank you, Professor Praveen and Professor Peter for the excellent talk, and Professor Praveen for the excellent moderation as well. I mean, I should add here that my thesis in my BM neonatology was guided by Professor Praveen. He's so knowledgeable, so humble, and I'm very happy to see him today. He's no less a legend himself as well. So thank you, sir. And in terms of questions and the earlier speakers, are everyone going to stay for the end? I mean, then we can proceed. So I'll go ahead with introducing the moderator for the next session, who is no other than the Dr. Rajiv. And all of you have heard about him from the earlier speakers as well as from Dr. Ramesh when they introduced. He is a renowned neonatologist who trained in the early 1990s. When I was early in medical school, he had already gone to Westmead in Australia. And then he trained there. After that, he came back and established one of the earliest neonatal intensive cares in the private sector in India. And neonatology was still in early infancy at that stage in the private sector, though it was established in some of the leading institutes like AIMS and PGA by that stage. And he went on to do fellowship in ventilation in Iowa and Washington as well. And he worked in multiple reputed centers in India. Then he moved to UAE in 2010. His main success has been the books that he published on CPAP, as well as the multi-authored Women's Guide on Neonatal Ventilation. So all of you have seen that in the introduction to this program. And he's having a great passion. He's a president of the IAP Emirates Neonatal Chapter, and have been lucky to be spurred on by his leadership during this period. Over to you, Dr. Rajiv.
Thank you, Sridhar. The way you introduced me didn't look like it was me. but all the same, I have to accept your introduction. Thank you, Sridhar. So I will introduce our very elegant next speaker, Dr. Martin Kreiber. He's the Chief of Division of Pediatric Critical Care at Beatrix Children's Hospital, Netherlands. And he serves as Medical President-elect of the European Society of Pediatric and Neonatal Intensive Care, ESPNIC. He's a member of the editorial board of the Pediatric Critical Care Medicine and frequently reviews international journals. His main academic interest relate to pediatric mechanical ventilation. He's the primary investigator for pediatric ARDS neuromuscular blockade study, and he has published more than 180 scientific papers and contributed numerous book chapters. He frequently gives lectures and workshops for critical care conferences. But more impressive are many of his studies which I read where he is the co-author. So we move on to Dr. Martin, and Martin, please take over from me. And we are bound to have a very good session. I'm sure from your background I read about you.
Thank you very much, Dr. Rajiv, for this great introduction. And it's a great honor and pleasure for me to be part of this webinar and among this esteemed faculty. So let me see if I can share my screen so that I can do my presentation. You see my screen probably now?
Yes, doctor. Can you make it in the presentation view?
Yeah. Is it okay?
Yeah, fine.
So for the next 30 minutes, I will talk a little bit about high frequency oscillatory ventilation and try to answer the question, is there still a place for HFOV? These are my conflicts of interest to disclose, although none of them are really related to the topic of this talk, so we can move on quickly. But before I'm going to elaborate a little bit more on high frequency, I'm going to be a little bit chauvinistic and tell you that the artificial respiration is not something really new, and it's something that comes out of my country because of the, we have a lot of waters, so we had a lot of drowning victims in the medieval ages. And I would everybody encourage to read this chapter in the Martin Tobin book, Principles and Practical Mechanical Ventilation, because it's a really nice history. But if we go back at the medieval ages, what did we do with the drowning victims? Well, we kept the patient warm. That is something that we still do nowadays. We gave artificial respiration through the mouth in those days. We still do that nowadays. And they fumigated the rectum with tobacco smoke, tried to resuscitate and revive the drowning victim. And if that didn't help, they placed stimulants orally and rectally. And if that didn't help, well, they did bleeding and then hoped that the patient would survive, which of course wasn't the case. Well, over the years, we have gained much more knowledge, but some things still happen by accident. And this also relates to high frequency oscillatory ventilation. And this is a really nice paper in the Blue Journal, about 20 years old now, written by Professor Charlie Bryan from Sick Kids in Toronto, describing how he came across high frequency oscillatory ventilation. And he was quite honest and said, listen, we stumbled onto high frequency by mistake, because they were doing a study where they were measuring the effects of muscle relaxants on lung impedance. And they set up the equipment for the studies, and they stuck a CO2 probe in the circuit. And they couldn't explain why they did it, but they did. And then they found at each breath hold, CO2 appeared in the mouthpiece in increasing amounts with each beats of the loudspeaker, eventually reaching end-tidal levels. So with a loudspeaker system, they were able to ventilate an animal. And this is what one of the first oscillators looked like. And the basic principle hasn't changed over those years, because for conventional mechanical ventilation, if you look at the pressure time scaler, you see this typical waveform on your screen with a peak inspiratory pressure, a positive end expiratory pressure if set, and the difference between the peak inspiratory pressure and the PEEP is the delta pressure. And you can calculate the mean airway pressure. Well, with high frequency oscillatory ventilation, of course, if you look at the scaler, you deliver a much higher mean airway pressure, and superimposed on that mean airway pressure are oscillations, and really small oscillations with a stroke volume that is below dead space, so below 2 ml per kg, at a rate between 3 and 15 hertz. So it's really much different from conventional mechanical ventilation. And early studies, experimental work, showed that high frequency was quite a easy way to ventilate because it decoupled oxygenation and ventilation. And if you look at this graph over here, you see the PaO2 plotted for a mean airway pressure in animals before lavage and post lavage. And at some point when the lungs started to recruit, you see a very nice linear relationship between the PaO2 and the mean airway pressure. And on the deflation limb, there was a linear relationship, but it was much more flat over a prolonged time, making use of histories of the lung. And this concept is important because it comes back later on in the talk. And they didn't observe such a relationship for ventilation. But the mechanisms of gas exchange, they are really complex, and they all have to do with how the pressure that is generated by the oscillator is delivered to the alveolar level. And this oscillatory pressure transmission, it depends on compliance and resistance of the respiratory system. Because as you can see in this really nice cartoon, we have two different alveoli, one that is well compliant and one that is poorly compliant. And in the one that is poorly compliant, there are larger pressure swings at alveolar level compared with the good compliance alveolus. And it's very nicely displayed in this graph. So with a decrease in compliance, the delta P, so the amplitude, so the pressure, oscillatory pressure amplitude increases. With resistance, before a resistance, because here you have an airway resistance, let's say in a bronchiolitis patient or some other viral pneumonia patients. So before the airway narrowing, there is a larger oscillatory pressure, and more distal from the resistance, there is a dampened pressure swing. So there is an attenuation of the pressure wave. And this is really nicely shown in this graph. And if you look at the orange line, that is the alveolar line, and this is the tracheal line. So the amplitude that the oscillator generates, how much is seen by the alveolus, is dependent on the compliance and the resistance of the respiratory system. And this is one of the already take-home messages early on in the part, because what we have been taught traditionally with oscillating patients is that we should set a amplitude. We use the amplitude to manipulate ventilation. But if you take these physiologic concepts into mind, then you would see that the amplitude should be seen as a monitoring parameter and not as a parameter that you should set. The big question, of course, is why should you oscillate? We have learned so much more of lung protective ventilation, and I think the previous presentation by Professor Rimmensberger was from such excellent talk. It really showed all these components. But let's try to summarize them in this graph. So here we have a pressure volume loop with pressure on the x-axis and volume on the y-axis. And here you have the inflation limb, which is the red line, and the deflation limb, which is the green line. And one immediately sees that these are not superimposed on each other because there is hysteresis of the lung. And we know from experimental work that on the inflation limb, there is a continuous recruitment and de-recruitment going on. And on the deflation limb, this is less prominent. But this means that the so-called safe zone of ventilation, so where you can ventilate your patient without being the least injurious, is really, really small. And traditionally, this cartoon was displayed with a safe zone, which is really this big, but we know on the inflation limb that there is continuous recruitment, de-recruitment. So the safe zone is mainly located on the deflation limb of the pressure volume loop. And we've learned over the years that we don't want to be in the upper part of the pressure volume loop because we don't want to cause overdistension by large tidal volumes, because then you get rupture of the alveolar capillary membrane. And we don't want to be in the lower part of the pressure volume loop because then you have lung areas that are still collapsed, as you can actually see in this image. You see lung areas that are open and there are lung areas that are still collapsed. And this is also injurious, which is atelect trauma. So we need to balance between atelect trauma and volume trauma by, well, delivering a small tidal volume, but nobody knows how small is. And by delivering, by setting an optimal level of PEEP, but nobody knows what the optimal level of PEEP is. And I will go through this quickly because Professor Rimmensberger already told this, but the allowable tidal volume depends on the compliance of the lung, which is compatible with the baby lung concept. So if you have a patient who has a moderate ARDS, the tidal volume that you can deliver is larger than in a patient with a severe ARDS, where the lung is less compliant and the tidal volume is much smaller because the safe zone becomes much smaller. This landmark paper published in 2000 by the ARDS Network showed that delivering large tidal volume, 12 ml per kg, was associated with a higher mortality compared with delivering 6 ml per kg. So everybody says, okay, lung protective ventilation until 6 ml per kg, that's fine because 12 ml per kg is bad. And yes, of course, the mortality benefit was quite impressive, going from 40% to 31%. But it doesn't mean that 6 ml per kg is the holy grail and it's the tidal volume that one should deliver. Because there is a group of patients that still suffer from overdistension with 6 ml per kg. And this really nice study from Taragni and Ciumello, published in 2007, highlight this phenomena. So they have patients with ARDS ventilated according to current standards, so 6 ml per kg, PEEP setting according to the PEEP FO2 grid. And then when these patients were placed in the CT scanner and measuring the overdistension at the end of inspiration, in some patients 6 ml per kg was fine, and these patients didn't have end inspiratory tidal hyperinflation. But another group of patients, not detectable from the outside, still had regional end inspiratory tidal hyperinflation, meaning that 6 ml per kg for these patients was still too much, and the tidal volume should be lower, which is of course compatible with the baby lung concept. So the sicker the lung, the lower the compliance, the lower the tidal volume should be. This would mean high frequency would be the way to go, but it's much questioned by many people saying high frequency is the end of the road. But the question is, do we really know how to use the oscillator in a good way? And if you don't do a trial properly, then you can ruin a really good technique. Let's go back to the question, do we really know how to use high frequency oscillatory ventilation? Well, let's go back to the paper from Professor Charlie Bryan. And this was a quite fascinating statement somewhere in this paper saying, well, you could do randomized controlled trials, but he said, well, I was allergic to randomized controlled trials because it was now clear that we were testing the driver and not the machine. So with the RCT for high frequency, the threat is that you're not testing the technique itself, but you're testing how it is applied by people. And the only thing to overcome this is education. But then you have one of the most famous scientists from the world, Richard B. Feynman, an American physicist, said, well, it doesn't matter how beautiful your theory is, it doesn't matter how smart you are, but if it doesn't agree with experiment, it's wrong. So you can say that high frequency oscillatory ventilation is a good mode of ventilation for patients with severe lung injury. But if the experiments, so the trials, if they don't show it, then your theory is wrong. Well, let's take a close look at the so-called experiment, because when people are talking about high frequency, it's not high frequency doesn't mean high frequency. It's not the same. The success of high frequency depends on the patient, depends on the oscillator, how it is set, and depends on the operator, the one who sets the oscillator. So find the right patient, use the oscillator by physiology, and change your mindset. So forget what you have learned about high frequency over the past years. Well, first selecting the patient. Well, the indications for high frequency, in my view, they are quite easy. I don't want this patient to die. And I think many people still use high frequency in that fashion all over the world as a rescue intervention. But you could also change your mindset a little bit and think, okay, I don't want ventilator settings, conventional ventilator settings, to become toxic. So if you are reaching a certain plateau pressure, you don't want to go above that certain plateau pressure because we know it's associated with injury. Hence, maybe moving to the oscillator. Personally, I think the oscillator is much easier to use because it had fewer knobs, but that's just my thing. And some people have asked, well, can you identify a proper patient using oxygenation parameters? Well, many people use oxygenation index as a threshold. We don't have a clear value, which is when to use the oscillator or not. But the adults have shown from a sub-analysis of their oscillator trial that if the patient has a baseline PF ratio below 100, there is most likely a benefit on outcome in those who are managed with the oscillator. So in severe ARDS, high frequency oscillator ventilation may improve patient outcome. The second aspect is let physiology guide the oscillator. So the current use of the oscillator is a cookbook. Many people set the oscillator frequency by weight, set the amplitude looking at chest wiggle or looking at CO2. Many people don't use a real lung volume optimization strategy. And even the RCTs don't make use of physiology. So it's a real cookbook approach. And I think this is something that we should throw out of the window. Because frequency, so the frequency of the oscillator, it has nothing to do with weight, it has nothing to do with age, but it has everything to do with lung mechanics. And it's quite complicated, and we only have 30 minutes, but if you take the concept of resonance frequency in mind and you trying to find the frequency at which the pressure cost of ventilation is the lowest, meaning that at that frequency, the injurious effects of ventilation are the lowest, that's the frequency that one should target during HFOV. And this optimal frequency depends on the so-called corner frequency. And the corner frequency is a frequency, and it's a formula, is influenced by compliance and resistance. And those are easy things we can see at the bedside. Look at this graph. So here you have the lung impedance, the pressure cost of ventilation, and here you have the frequency. This is the line for a normal patient. This dot represents the corner frequency. At this point, the pressure cost of ventilation is the lowest, meaning the injurious effects of ventilation are the lowest. In patients with a decreased compliance, so those with ARDS, the corner frequency shifts to the right. Look at the formula, the number becomes lower, so the corner frequency goes up, meaning that in patients with ARDS, you should go in the higher range of frequencies. So if you have, let's say, an 8-year-old patient, don't set the frequency at 8 Hertz because the patient is 8 years old. No, if the patient has ARDS, go at 12 or 15. For patients with increased airway resistance, so the status asthmaticus, is quite the opposite. They need a lower frequency because with increasing resistance, the corner frequency shifts to the left, meaning that the frequency that you should set should be lower. But for ARDS patients, so for those with a decreased compliance, you should target the highest frequency possible. Many people, when they go to the oscillator, they don't do a recruitment strategy. And experimental work really shows the necessity of, underscores the necessity of a lung volume optimization maneuver. So here you have the volume above FRC for a mean airway pressure, conventional mechanical ventilation, high frequency, just setting a pressure, doing nothing, and then doing a lung volume recruitment maneuver. And with increasing pressure over time, you see that with the ones who are recruited, there is a greater degree of lung aeration, so more lung recruitment. And in those with a more lung volume recruitment, there is a lower degree of lung injury. So a lower deposition of hyaline membranes as marker of lung injury, and a lower degree of epithelial injury. And this is because with a recruited lung, the pressure amplitude is smaller than with a non-recruited lung, as we saw in the beginning. So this really underscores the need for opening up the lung when you have gone to the oscillator. And another benefit of doing a lung volume optimization maneuver is that you can make use of hysteresis of the lungs. And this is really nicely shown in this graph. So we are increasing the pressure in this patient and the lung is opening up. And then when we are decreasing the pressure again, when we are on the deflation limb, one immediately sees that for the same pressure on the deflation limb, the lung is aerated versus a non-aerated lung on the inflation limb. So a lung volume optimization maneuver not only attenuates lung injury, but also allows you to have the lung more recruited and in the end requiring less pressure. lung recruitment is a time-consuming technique, and that's why the adults used the so-called 40-40 rule in their trials. And with the 40-40 rules, what they did was they applied 40 centimeters of water for 40 seconds. And by doing that, they hoped to have fully recruited the lungs. And then they set the initial mean airway pressure at 30 centimeters of water, hoping to be at the safe zone of ventilation. And this is a maneuver that takes, well, let's say 2 minutes max. But the problem is, if you have a patient with a severe ARDS, where the pressure volume loop is flattened, it's the inflection points are shifted to the right, the hysteresis is gone. If you would then apply 40 centimeters of water for 40 seconds and reduce your pressure to 30, you would get a significant de-recruitment. And for another patient, applying 40 centimeters of water for 40 seconds and then going back to 30 would mean that this patient would still be in overdistension. So a sustained inflation ignores the individual respiratory system mechanics of the patient and is, in my view, not a good lung volume recruitment technique. What would then be a good technique? Well, the problem is we don't have that much data. We have this really nice neonatal LAMP study from Peter Dargaville's group comparing a incremental mean airway pressure titration to recruit the lung versus a sustained dynamic inflation or repeated dynamic inflation. And they measured our control and they measured thoracic gas volume and they performed single slice CT scanning in all those animals. And what they found was that the escalating recruitment maneuver, so staircase incremental mean airway pressure titration, resulted in the greatest lung aeration with the lowest proportion of poorly aerated lung. So a stepwise incremental mean airway pressure titration to find the best mean airway pressure for your patient when you have gone to the oscillator seems indicated at this moment. Then back to the amplitude, as I said in the beginning, well, amplitude, the delta P, what you see on your screen is not the same as power, because the power is a dimensionless knob that drives the piston. And the piston, the movement of the piston generates a amplitude, and that amplitude depends on the compliance and the resistance of the respiratory system, as I showed you in the beginning. So this means that you should use the amplitude as a marker and not as a setting. So the amplitude gives you information what is going on with your patient. But this is all theory, but the problem is that the data contradicts our theory, and this is the one of the most cited studies in that context. That is the Oscillate trial from Neil Ferguson and Deborah Cook from Canada, which was by design a very nice trial because for the high frequency approach, they reported the 40-40 rule, which made some criticism, but it was really protocolized. But the control group was also really protocolized, and the control group was based on experiences with a recruitment study and the LOVES trial. So it was a consensus for the high frequency approach versus a more or less proven approach for the conventional mechanical ventilation. But the problem with that trial was that although it was really nicely designed, that in the end, they didn't achieve very high frequency, although it was in their protocol. The frequencies that were achieved with 5.5 hertz, which would mean really large side of volume in these adults. They managed oxygenation by a MAP FiO2 table, and a MAP FiO2 table is based on the PEEP FiO2 grid. And although there is some data from CHLA showing that there's a signal in patient outcome, the PEEP FiO2 grid and this grid are non-validated grids, and they have nothing to do with physiology. And I said the control group was strictly protocolized. So the trial by itself, the design was okay, but the signal was not there. And this trial was stopped prematurely after 550 patients because the mortality in the high frequency group was significantly higher compared to the control group. And it was death in hospital, it was death in the ICU, it was death for 28 days. What's worse in the high frequency group compared with the control group? Interestingly, these patients did not die from refractory hypoxemia. because as you can see that the refractory hypoxemia was significantly lower in the high frequency group compared to the control group, confirming what Professor Rimmelsberger said, that hypoxemia doesn't kill you. Other studies combined the two adult trials with high frequency and older adult trials stratified by tidal volume. Didn't find a effect of high frequency over conventional mechanical ventilation in adults with ARDS. So does it still have a place? Well, the theory says yes, but the adult data isn't that supportive. Well, this is the MAP FR2 grid, and it had nothing to do with physiology. The problem is that we don't have really good pediatric data. There is only one randomized controlled trial published by John Arnold in 1994, a randomized crossover trial of only 60 patients, and they didn't find a mortality benefit of high frequency over conventional mechanical ventilation. They did find that there was a lower need for oxygen at 30 days, but that's not a real strong objective criterion, so no mortality benefit. And then it became quiet for many, many years until this analysis of a database was published by Dr. Gupta and Dr. Wetzel from Los Angeles. And they analyzed data from the virtual PICU database and matched patients using a propensity score because it's a database study. But unfortunately, this database was not having any information along mechanical ventilators and experimental high frequency, nor did it mention how high frequency was used. So they were only able to examine the outcomes associated with high frequency and conventional. And they found that there was a much higher mortality and a much more time on the ventilator in those who were managed with the oscillator. And it didn't matter if it were all patients or if it were those patients who were managed earlier with high frequency. In each analysis, high frequency was associated with adverse outcome, so a higher mortality and a longer time on the ventilator. The problem with this study is that there are so many unknowns and so many confounding variables that have not been adjusted for that it is probably not right to state that high frequency doesn't have a place based on this pediatric study. The conclusions by the article itself, they were stated too boldly, and the propensity matching, for this propensity matching, if you don't know what propensity matching is, one of the serious concerns of bias in database studies is so-called confounding by indication. Confounding by indication means that the patient who is the most sick is the most likely to get a certain intervention. And you have to adjust for that. So you can adjust for propensity matching, and propensity is the likelihood that a patient is getting a certain intervention based on variables that one identifies. For this propensity matching, which is nothing but a logistic regression analysis, you have to put in variables in your model that make sense and that have to do with the decision making when to start high frequency. So let's say peak inspiratory pressure on conventional, FI2 on conventional, timing, etc., etc. But because all of this data was lacking in the virtual PICU database, the authors used variables for propensity matching that had nothing to do with the decision making when to start high frequency. So the discussion on high frequency is really, really troubled by this particular study. Some of these limitations were addressed by Scott Bateman and Martha Curley, who performed a secondary analysis of the RESTORE data set. The RESTORE study was a trial comparing sedation approaches in the pediatric ventilated patients. And they studied the effects of high frequency versus conventional by comparing early versus CMV. And they did not find increased mortality with high frequency, but they did find a prolonged time on the ventilator. So the really strong effects as observed by the Gupta study were not confirmed, but indeed patients who were managed with high frequency spent more time on the ventilator, even after adjusting for disease severity and all other known confounders. So the duration of mechanical ventilation, for example, was 15 days in the high frequency group versus 10 days in the conventional group. So again, brings back the question, is it the end of the road? No, well, we have we don't know how to use the oscillator in a good sense. And this is something that has also been addressed by Neil Ferguson in this really nice review article in Chronic Pain Critical Care. Because if you are going to use the oscillator, you have to balance frequency, you have to find your mean air pressure, and you have to find the optimal mean air pressure. And if you don't find the optimal mean air pressure, so if there's no balance between overdistension and recruitment, you get all these negative side effects. The frequency, if you don't use the highest frequency possible, you are going to deliver larger tidal volumes than anticipated, and you are going to attenuate the potential lung protective effect of the oscillator. So we try to summarize these differences in high frequency approach in this paper and coined it high frequency 2.0. And high frequency 2.0 means an open lung strategy oscillating on the deflation limb by doing a stereous recruitment maneuver in all patients, the highest possible frequency. For example, in our unit, we start at 12 Hertz in all patients, irrespective of age or weight or cause of the ARDS. And a high fixed power setting, so targeting an initial proximal pressure amplitude of 70 to 90 in all patients, and then using the proximal pressure amplitude as a marker of what's going on in your patient. When you do recruitment, many people are afraid of pressure. And the question is, how high do you need to go with pressure? Well, we characterized all the recruitment maneuvers we have done. And we found that the lung was open at a mean air pressure optimal of about 28 centimeters of water. And to achieve this 28 centimeters of water, we had to go up to a median of 37 centimeters of water with the IQR of 34-38 to find this optimal mean air pressure at the end of the maneuver. Meaning that if you have a patient on conventional and you're going to high frequency, you should not be afraid of pressure, and you really need to crank up the pressure to really open up the lung. So in summary, for that, open up the lung with about 26 to 34 to 48 centimeters of water, and then you find your optimal air pressure somewhere between 26 and 34. And if you know these numbers, if you see these numbers, and these come from the characterization of about 50 to 60 individual lung volume recruitment maneuvers, then you already understand that a so-called 40-40 rule, and then going back to 30, may be of benefit in some patients, but you ignore many, many other patients. This high frequency 2.0 approach, so high frequency, high fixed power setting, open lung, is it safe and does it work? Well, one of our PhD students, one of our attendings, collected the data on all these patients, 115 children over a 3-year period, of whom about 20% had severe ARDS. And I said it's a high initial frequency in all patients, high initial delta P in all patients, and all patients underwent a staircase incremental mean air pressure titration, which is a lung recruitment maneuver which takes about 45 minutes, but it only one that allows us for an individual setting of the mean air pressure. And we could show that it indeed was feasible because, well, we used high pressure in all those patients and it did decrease over time. These are hours, so 6 hour, 12 hour, 24 hours, 36, 72 hours. But it was irrespective of what kind of ARDS the patient had, high pressure. We were able to maintain an amplitude of 70 to 90 in all these patients during the first 3 days, and a frequency that never went below 8 Hertz, so really compatible with the corner frequency concept. And although you would say, okay, this is a really high frequency and this is really high pressure, what about oxygenation ventilation? Well, oxygenation ventilation works really well with this new approach. So here you have the oxygenation index or the PF ratio, and you see when you go to the oscillator, an increase in oxygenation index, which makes sense because we use high mean air pressure because of our open lung concept. But especially in those with severe ARDS, you see a really strong improvement in OI over time. And a strong improvement in PF ratio over time. And despite having this high frequency, we were able to really adequately ventilate the patient because the CO2 was, and the gray box represents the conventional on this high frequency, the CO2 was even within normal limits when the patients were on the oscillator, despite the frequencies above 8 to 10 Hertz. And the pH was in the normal range as well, suggesting that we might have even gone going higher with high frequency. So this alternative approach, it improves oxygenation, especially in severe parts, and it gives a good CO2 clearance despite the high frequency. And it doesn't have any effect on hemodynamics. In fact, stratified by age, we saw a normalization of the heart rate. We saw a normalization of the central venous pressure. We didn't see an increase in or a decrease in mean arterial blood pressure, and we didn't see an increase in lactate, indicating that this open lung approach, by really opening up the lung, giving high pressures, didn't cause a hemodynamic compromise. And it was also irrespective of part severity. It all sounds very easy, but the device itself, it doesn't have a brain. This sticker should be on your device, so you have to use your own brain. So if you were to summarize where we are today now with high frequency, well, we can say that a premature trial can kill a good technique, well, at least almost. We've seen it happen with the neonatal trials earlier on, and now we've seen it happen with the 2 adult trials. Mindsets are harder to change than machines. So this high frequency 2.0 is completely opposite of what many people have been taught for over many, many years. So changing the mindset, that's going to take some time. And ventilator strategy must be driven by patient pathology and not by a cookbook. But hopefully we are going to get an answer about high frequency auscultatory ventilation. So right now the Prospect trial is being conducted. A trial being led by Martha Curley, Ira Chaifetz, and myself, which is a 2x2 factorial trial comparing high frequency versus conventional and prone versus supine position in patients with moderate to severe ARDS. And we hope to have show you the results in 3 or 4 years' time. And this is the trial in brief. So what should you do in practice? Well, right now, high frequency, yes, use it and follow the guidelines, because the PALEC, as already cited by Professor Rimmesberger, well, consider high frequency as an alternative ventilator mode, not as a rescue mode, but as an alternative ventilator mode when you are reaching toxic conventional ventilator settings. And PEMVAC more or less says the same. And if you do that, use a open lung strategy to maintain optimal lung volume. So, no data to abandon the oscillator for parts at this stage. It can be considered in case of moderate to severe oxygenation and or ventilation difficulties with potentially or already present toxic conventional ventilator settings. And the big issue with high frequency is that it's not the oscillator per se, but rather how we use it. And in contrast to what everybody has been taught, I really advocate high frequency, not dictated by 808, a staircase recruitment maneuver, and using the amplitude as a monitoring parameter and not to target a specific delta P. And I'm still convinced that high frequency is the ultimate tidal volume strategy, it's the ultimate lung protective ventilation strategy. But it's true, we need to learn how to manage the oscillation in an optimal fashion. And I hope with this talk, it will help you a little bit towards that direction. Thank you very much. And I give the floor back to the moderator.
That was a fantastic. Am I audible, Martin?
Yeah, I can hear you. Yeah.
That was a fantastic talk, because despite my almost 30 years with high frequency, we have done well in the newborn side, honestly. Because probably my center was the first trained by Martin Kessler to start in '97. That's almost 25 years back. And I have never looked back with the high frequency in the neonates. Any lung, we had a strategy in which we could get the kid out. But seeing your lectures, I have a few questions on the pediatric side. Can we say that it is purely a mindset and the cookbook thing which foiled your attempts with the pediatric side? Or was it a side breath approach which came later? You said step-by-step improvement lung recruitment, which was not visible for 10 years, and why you're succeeding now after so many years of high frequency, you know, almost 3 decades.
Yeah, it's probably a combination. I think many people have been taught, okay, I have to use high frequency this way, and I'm going to use it for the rest of my life.
Yeah.
Then there came the 2 adult trials, and then people who were still using high frequency were more or less told by non-users, oh, why you're using this device because it's not working and you're killing patients. So forget about that machine. And well, we learned so much more about conventional mechanical ventilation that at some point, well, you don't know what the balance is, and that maybe at some point our knowledge of conventional mechanical ventilation has improved so much that there will be a signal for a better outcome with high frequency in a really small identified group of patients. And well, that's the one we try to target in the prospect.
After this cardiac hemodynamics came in a big way, did you target specific cardiac hemodynamics before you ventilated the baby?
Well, we said we try to achieve a mean blood pressure which is more or less in line with what we would expect. But as long as we don't see a real problem with central venous pressure or a problem in lactate or any other marker, then we can accept it. And I think it all has to do in the end with, you know, this U-shaped curve of the pulmonary vascular resistance and the lung volumes, where on one end you are at the residual volume and your PVR is high, and on the other end you have TLC and your PVR is high, and in the middle at FRC or end expiratory lung volume, when you're on the ventilator, your vascular resistance is the lowest. And I think with high frequency, it enables us a little bit easier to stay in that part of that U-shaped curve.
Hopefully, yeah, it's actually hopefully, because I think after this cardiac hemodynamic monitoring became very, very intense. Like in my book, I think I've given you my book. Yeah. So I find it makes a dramatic difference into your ventilatory strategy, because I had a student who I trained in the 90s. He came back to me in 2000. And when I was doing high frequency, he told me, sir, your preload is fine. Why do you want to give more fluid? So I have a feeling this area, when you do more research, Martin, good to look into your hemodynamic, the right ventricular output, the right ventricular function, everything, and then be sure that are we optimally hemodynamically correct in the treatment of the lung volume and the FRC.
Yeah, no, that's an excellent point. And the colleague who did the database study and in the ARDS patients, he's now going to publish a similar paper in about 55 cardiac patients, showing no negative effects also on heart rate, central venous pressure. So it's on terms fine, but it's really fascinating to do, let's say, esophageal echo studies to measure, to see what happens with the right ventricle. That probably would be the next step.
Yeah. Thank you, Martin.
Yeah.
I think shall we move on, because that was a fantastic thing and it's very close to my heart, because in almost 97, we were a training center in India for training people in high frequency. And I used to smoothly go from mean airway pressure of 12 to high frequency and no problem. That was a time in the world when people were contesting whether high frequency is working or not. Yeah. Thank you, Martin. Excellent.
Thank you. Thank you.
Thank you. I mean, it was really excellent, as Dr. Rajiv said, fascinating. And you made it look so simple. Some of the concepts related to the frequency, even in newborn, I mean, I'm a neonatologist as well. So we still wonder which frequency to use, and the way you put that, choose the highest frequency that the baby will tolerate. It's very nice. Thank you, and fascinating. And continuing this fascinating journey today, we'll be inviting the next moderator, my dear friend and colleague, Dr. Deepu Abraham. So we worked together for close to 3 years at Zulekha Hospital, and now he's heading the unit there. And he trained in India as well as in UK for Trivandrum, and then he worked as a consultant in Chiesi and Westminster before he had a short stint in India and came back to UAE now. He's well established here now, and he's very knowledgeable, very professional in his approach, and has a good interest in PICU as well. So over to you, Deepu.
Thank you very much, Dr. Sridhar. Thank you for that kind introduction. Prone positioning has been used for ARDS and severe hypoxic cases to improve the oxygenation. And we have the best person to talk about this. For those who have missed Dr. Rajiv's introduction of Dr. Martin, he's the Chief of Division of Pediatric Critical Care Medicine at Beatrix Children's Hospital, University Medical Center, Groningen, Netherlands.
He's the president-elect of ESPNIC, the European Society for Pediatric and Neonatal Intensive Care. He is the member of the editorial board of Pediatric Critical Care Medicine, and his academic interest relates to pediatric mechanical ventilation. Martin, please.
Thank you very much for your kind introduction. Let me see if I can share my screen again. It should be visible now.
Yes. Please.
Presentation. So for the next 15 minutes, well, the true expert on prone positioning is, of course, Martha Curley, but I will try to act on her behalf. Prone positioning in pediatric ARDS. Well, my conflicts haven't changed over the past 30 minutes, so that's quite easy. This is, I think, has been alluded to in all the previous talks. Again, ARDS is a heterogeneous disease, and this is a dramatic chest radiograph that we can see in the unit. And if you would put the patient in a CT scan, you would see images like this, really dramatic overdistension, collapsed areas, really thick lungs. So the hallmark of ARDS, of course, is hypoxia and hypercapnia. And you have a combination in a patient where you have shunt, so there's perfusion without ventilation. There is some ventilation without perfusion, which is dead space. And if you know this physiology scheme, schematic, and try to put it on this patient, well, you can imagine what is going on in your patient. There is a dead space because there's overdistension. You have ventilation, but the capillaries are compressed. Normal areas and the shunt in the areas that are collapsed. And this all contributes to the hypoxia. And the hypoxia is further aggravated by the gravity. So here we have a patient. Patient is in supine position, ventral, dorsal, here's the vertebrae, and there's a superimposed pressure. And if you go from ventral to dorsal, the superimposed pressure increases. And under normal conditions, there is a moderate increase, and the ratio of aerated versus non-aerated lung tissue is pretty well reserved, because otherwise we would be in problems when we go to sleep at night. But then we have the patient with the ARDS, and there will be edema, alveolar flooding, there will be inflammation, there will be destruction of tissue. And because of the edema, the lung will become heavier, and the effects of gravity will become more prominent, and the superimposed pressure will be much stronger, and the ratio of aerated versus non-aerated tissue will negatively change dramatically, leading rise to a much larger degree of non-aerated lung tissue. And then if your patient is hypoxic, and I borrowed this slide from one of Peter's talks because I think it's a really fascinating slide. If your patient is hypoxic, consider turning the patient. And this concept was already tested at the end of the previous century, where they had a hypoxic patients, several patients, and they turned the patients from supine to prone positioning. And in almost all patients, they saw a dramatic improvement in the PF ratio, going from a PF ratio compatible with severe ARDS to PF ratios compatible with moderate or even mild ARDS. Also notable that not all patients were really important responders. So this was a first suggestion. And it's not only the oxygenation, but it's also the ventilation. And this is a really nice analysis of data obtained in randomized prone trials published by Luciano Gattinoni in Critical Care Medicine 2003, where they found that patients who had an improvement in PO2, and it was defined as more than 20 millimeters of mercury increase, and if they put those responders versus non-responders in a logistic regression model, it did not really seem to impact the outcome of those patients. Whereas in those patients, if they stratified them by a response in improved ventilation, which was quite more than 1 millimeter of mercury decrease in CO2, they found that those who had a CO2 responders, they had a much better outcome than those who didn't respond in ventilation. So it's not only oxygenation that you might improve, but also ventilation. And if your ventilation improves, that is a strong indicator for a better patient outcome. And these were the numbers, because if you look at the CO2 responders and the oxygenation responders, you could see that the mortality rate in that group was 34%. But in a group who had a CO2 responders, but an oxygenation non-responders, the mortality was only slightly higher, 36%. But in those who didn't respond in ventilation, so in those whose patients whose ventilation wasn't improved, but the oxygenation improved, mortality was almost 55%. So it's the ventilation itself that also determines the outcome of those who are prone. Well, the first suggestion, it was not just a paper in 1997, but it was made much earlier. Again, in a paper from Professor Charlie Bryan from Sick Kids in Toronto, where they said, well, it's the devil is in the detail. And in supine position, there is an association with a volume deficit in the dependent parts of the lung. And anesthesia work was in line with this. So here you have a patient who is awake and spontaneous in supine position, then a anesthetized spontaneous breathing patient. But if you see in a paralyzed patient, there isn't a displacement of the diaphragm, the posterior part of the diaphragm, but it's more the anterior parts of the diaphragm. And what happens in a paralyzed patient, the volume is directed towards the non-dependent part of the lungs, thereby creating more overdistension and increasing the dead space. And in a patient who is breathing spontaneous, there is a direction of the tidal volume towards the dependent part of the lungs. It does not mean that every patient should breathe spontaneously. I think Professor Rimmelsberger really excellently showed the concept of patient self-inflicted lung injury in patients with severe lung injury. Spontaneous breathing may actually may worsen the situation rather than improving the situation. But this is the general concept of the prone positioning. If you have a patient who is supine, there's gravity and there's the weight of the heart. So here you have 4 CT scans of patients in a supine position. And in a supine position, the area of lung below the heart is much larger than when the patient is in prone positioning. Meaning that in a supine position, there is a greater degree of lung tissue at risk for collapse due to the superimposed pressure. So with prone positioning, you get you flip the patient, there's still the gravity, but you get a better shape matching. And over time, in the end, you see that the lung aeration becomes more homogeneous across the lung compared with a patient who is in supine position. And this is nicely shown in this study from Gattinoni, where they calculated the gas tissue ratio in patients who were supine and then who were subsequently moved into prone after some time when the shape matching and the gravitational effects were accounted for. And then if you look in when they were in the supine position, let's take the ARDS patients, so these are the ARDS patients, though, that in the non-dependent parts of the lung, the gas tissue ratio was greater and it decreased in the dependent parts of the lung, meaning that the non-aerated lung tissue was larger in the dependent lung zones, whereas in the supine, in the prone position, this was more or less homogeneous throughout the entire lung. So you get a better distribution of your tidal volume, and you get a better distribution of your transpulmonary pressure and shape matching when the patient is in prone. And we've heard a little bit about lung stress and strain in the earlier talk. And in prone positioning, there is a lower strain for a given transpulmonary pressure, so stress, when you are in prone positioning, the black bars compared with the supine positioning. So let's say if you even have a large transpulmonary pressure for 30 centimeters of water, the strain is significantly lower in the supine, in the prone position compared with the supine position. And this effect stays the same if you would decrease the lung stress. So from a physiologic perspective, there is lots of suggestions that prone positioning should be implemented in your routine care. And it's not only the shape matching and the distribution of the transpulmonary pressure and the tidal volume, but it's also the perfusion. So this is an animal study where they found that when animals were who had lung injury induced by oleic acid, which is a really aggressive substance to cause lung injury, they found that when in the prone positioning, the blood flow was opposite compared with the supine positioning and improved compared with supine. So if you look at the dependent zone, there was a lower drop in the, there was a lower blood flow, but then of course that's where the heart is and where there is a lower lung area and more perfusion in the non-dependent lung zone. And in the same animal work, they found a effect of prone positioning on the pleural pressure gradient, which affects, of course, the perfusion. So this is a really nice study. And let's look at this graph. So here you have animals. It was a volume study, so we only look at the data before the infusion. So here you have the animals who were in supine position, here and you see them in prone positioning. And what they found that in the non-dependent zone, the pleural pressure became less negative. And in the dependent lung zone, the pleural pressure became less positive, meaning that overall the pleural pressure gradient became smaller in prone positioning, which would mean a more homogeneous distribution of the transpulmonary pressure. And this was confirmed in a healthy human model. So this is a human in supine position. And here you see the pleural pressure gradient, and you see the difference, and you see a strong pleural pressure gradient in the ventral parts compared with the dorsal parts. And then if that model was positioned prone, the pleural pressure gradient was more or less consistent throughout the entire lung. So there is a better distribution of your transpulmonary pressure. And there are many, many other effects. And if you look at the effects of prone patient positioning on respiratory mechanics in ventilated ICU patients, you would see that your end-expiratory lung volume increases, your resistance will drop or stay the same, your respiratory compliance will improve or stay the same, and that's mainly because the lung compliance improves, because the chest wall compliance, and that of course makes sense, drops because you flip the patient, chest wall compliance drops. Driving pressure stays the same, intrinsic PEEP will reduce, and oxygenation will improve. So there are a lot of mechanic benefits of prone positioning in ARDS. But again, this is the theory, and you have to match it with the experiment. And early work wasn't that really supportive of prone positioning, because Gattinoni showed in his paper in 2001 that indeed oxygenation improved, but if they looked at the survival, it was not different between the patients who were randomized to prone versus those who were randomized to supine. So there was no effect whatsoever. This is an all-comers ARDS. That's something that you should take note of. For pediatrics, the same. This is the one randomized controlled trial that we only have from Martha Curley, published in JAMA in 2005. But she also confirmed a strong improvement in PF ratio in those who were managed with prone positioning and a drop in the oxygenation index. But if she looked at ventilator-free days, which was the primary outcome, then there was no effect on ventilator-free days between supine and prone. So patients who were randomized to prone did not spend a shorter time on the ventilator compared with those who were randomized to supine. The question is, and it's probably the same question as with high frequency, should you use it for all patients or should you use it for those with severe ARDS? And if you want to use it for severe ARDS, we need to identify what severe ARDS is. This is the Berlin definition, the adult definition of ARDS. And this is the pediatric definition of ARDS, the PALIC definition. And in the adults, severe ARDS is defined by a PF ratio below 100 with a minimum PEEP of 5. For the pediatric version, it is defined severe ARDS as a oxygenation index equal or greater than 16, or if you don't have an indwelling arterial line greater than 12.3. So maybe for severe ARDS, proning indeed improves patient outcome. Well, that thinking was more or less translated into this systematic review, where they stratified all the data that was out there on prone positioning by PF ratio in a group with PF below greater than 100 or below 100. And in those with a PF ratio below 100, so compatible with the severe ARDS, there was a strong signal for a better outcome in patients managed with prone positioning. And for all other patients, this signal was statistically insignificant. So prone positioning should probably reserve for those with severe ARDS. Well, that finding was used by Claude Guérin in his landmark paper, randomizing adults with moderate to severe ARDS because they had a PF ratio of cutoff of 150. With greater P of 5 and FR2 greater than 0.6 in a multi-center study where they were randomized to prone positioning for at least 16 hours per day throughout 28 days. And what they found was a strong effect on patient outcome, a much higher survival in adults managed with prone. So the mortality dropped from 32.6 to 16%, and also 28 ventilator-free days at day 28 was much higher, meaning that patients who were randomized to prone spent a shorter time on the ventilator. So in adults, prone is, because of this study, it's in and in all the concepts. The question is it only linked to the severity of ARDS? Because we see this systematic review with PF 100, but the trial, the Guérin trial, had a PF of 150 as cutoff point, or should we consider other aspects of lung protective ventilation into account, in particular the role of tidal volume? Because if you look at the trials that did not show because the trials that were studied, they had a tidal volume that was all over the place, going from 10 to 6 in the Guérin trial, with mortality all over the place. But they mainly found that in those trials who use low tidal volume, the effects of prone positioning were prominent. So if you are going to prone your patient with moderate to severe ARDS, it doesn't give you a carte blanche to use a large tidal volume. You should still adhere to lung protective ventilation recommendations and use the lowest tidal volume that is allowed to allow for adequate gas exchange, because only then you can actually improve patient outcome. So if we know this and we go back to the Martha Curley trial, the only pediatric trial we have, the PF ratio, well, in the patients there was about compatible with what Guérin had included. So the baseline was around 150, but the tidal volume was, well, almost approaching 8, so a little bit higher than what you would expect in terms of lung protective ventilation. So where does this leave prone positioning pediatric ARDS nowadays? Well, I think Peter cited our study many times, how to manage ventilation. We have so many unknowns. Same goes for what is in the PEMVIC unknown. And if we look at what the adults have built in, again, for the part severity, increased severity, that at some point, if you have moderate severe ARDS, you should consider prone positioning or high frequency. Disclaimer, in our unit, we use first the oscillator, and then if the patient doesn't improve, then we move to prone. But I think there are many units where they don't have the oscillator. They would go to prone in case of oxygenation impairment, which of course is fine in line with this compatible. Proning has gained much interest during COVID-19. And many studies have been reported. And yes, in COVID-19, it does reduce mortality, even in awake prone patients. It doesn't reduce the need for intubation. So if you want to improve outcome, yes, but it doesn't avoid the anatractic intubation on patients. again, this is all adult data because there is very, very little pediatric data, unfortunately. Well, where are we now then with prone positioning at this stage? Well, PALIC, and this is the 2015 recommendation, and as Professor Rimmelsberger already mentioned, the revisions are currently underway and should be published hopefully this year. But in the PALIC, it is said, well, it cannot be recommended as a routine therapy in ARDS, but it should be considered in an option of severe ARDS. You could go moderate severe ARDS, and we need further studies. And that studies are coming. Well, this is the same study as I showed in the previous talk, the PROSPECT trial. And PROSPECT not only studies the effects of high frequency versus conventional, but also prone versus supine positioning. And we are also going to explore if there is any benefit of combining the two, so high frequency plus prone positioning. Well, patients with moderate to severe ARDS are randomized to either one of these 4 boxes. And then we are going to check our primary outcome, which is ventilator-free days. And the secondary outcome is organ failure-free days. And we are going to measure if there is an interaction between one of these boxes as well. So prone positioning improves oxygenation and outcome, especially in the context of severe ARDS, moderate to severe ARDS. There's no supportive data in pediatric ARDS, so routine prone positioning cannot be recommended at this stage. The PROSPECT trial is designed to study this, and I said I hope we can provide you with some answers over the next 3 to 4 years. But if at this time, if you want to use prone positioning, if you have a patient with severe ARDS and you have tried all other measures and you don't have, for example, ECMO available, or you don't have an oscillator available, then I think you are really okay to prone your patient. And with that, I would like to thank you very much for your attention and give the floor back to the moderator.
Thank you, Martin, for that brilliant talk. Completely agree that the COVID pandemic has put the highlight on proning a lot. But do you think that proning is still underutilized, or is it still underutilized in severe ARDS? Your thoughts?
I think it is, but I think it's getting more and more used. I know, for example, there are units who have discarded their oscillator because they learned from the adults that proning improves outcomes, so they move to proning. So I think that the number of pediatric patients that is being proned is increasing over time now. And well, as you highlighted as well, I think, well, COVID gave it a boost.
Sure. Yeah. Thank you very much. I think we'll take any further questions towards the end of the session.
Thank you, Deepu, and thank you, Martin, again. I hope all of you will be there for the combined panel discussion in the end, which will be quite interesting with all of you in this. I mean, all of you being experts in the field, and I'm sure you'll shed light on many important topics. And now we have the final lecture, after which the panel discussion will take place. And thank you, Dr. Daniel, for coming despite not being very well, and really appreciate your commitment. It would be my pleasure to introduce the moderator for this session, Dr. Junaid Khan. So is Dr. Junaid there?
Yes, I am there very much.
Yes. Good evening, Dr. Junaid. So Dr. Junaid is a very familiar figure in Middle East, and you can say the whole of Southeast Asia. And he travels all over the world. He organizes conferences, and he's very, very academic. He's currently consultant neonatologist, and he's the chairman of the academic affairs in Sheikh Booth Medical City, which is collaborating with Mayo Clinic, USA. He has his conference every year, which is one of the most popular neonatal events, and we are lucky that he puts together a great program. Last couple of years, it has been online, and obviously, he's going to introduce Dr. Daniel. Over to you, Jamil.
Yeah, thank you very much, Dr. Sridhar. It's my pleasure I hope, Daniel, you are feeling well, and we are pushing you into this. But it's my pleasure to introduce you. Dr. Daniel Zulekha is the full professor of neonatology at Paris Society University. He is currently the chief of the division of pediatric, transportation, and neonatal critical care. He is the editor of the European Journal of Pediatrics. He did his MD from the Catholic University of Sacred Heart, post-graduation in pediatric emergency, post-graduation diploma in neonatal perinatology, PhD degree in biochemistry and clinical molecular biology. He's the MBA in the hospital management. So without further ado, this is the last but the most important session, or one of the most important session. Dr. Daniel Zulekha, the mic or the screen is over to you.
Thank you very much. I'm very happy for the invitation. I'm sorry for the misunderstanding, but I'm actually on call right now in the ICU. So if I'm called, unfortunately, I will have to leave very quickly, and I'm sorry for that. And I won't be able to stay for a long time for question time later on. So let me start very quickly. I don't know if you see my slides. Do you see that?
Yes, doctor.
Okay, great. So basically, I'm going to talk about surfactant steroids and pulmonary vasodilators as a sort of auxiliary therapies for ARDS. And obviously, as you can imagine, we have not very many data in pediatrics about that. So I'm forced a little bit to take some data from adult and even from the neonatal experience to cover these topics. And some of that you may find in this review. I published it almost 10 years ago, and it's very pity to say that there is not very much of evidence compared to 10 years ago. So that's a field that, you know, it's still struggling a little bit because probably not enough patients to do very high quality randomized controlled trial. Despite for some of these interventions, there is quite a strong background behind. So I can only refer you again and again to the ESPNIC PEMVIC recommendations for everything about mechanical ventilation and monitoring, although these drugs are not covered by these guidelines, but I'm sure Martin said something more in detail about that just a few minutes ago. And as you know, we now have definitions for ARDS at any patient's age, so for adults, for children, and even for neonates. And this is really the first step to use in order to optimize the treatment of these patients. So having said that, let me go straight towards surfactant. So surfactant has a very long history, and we all know that when you have a patient with ARDS, you almost unavoidably have surfactant damage, which is both quantitative and qualitative, but it's also linked to very high lung tissue inflammation and endothelium and epithelium injury, depending on the type of ARDS. So again, the largest experience about that is coming from neonates. And if you take the meconium-induced ARDS, so the meconium aspiration syndrome, which is a sort of a archetypical type of primary direct aspiration-related ARDS, you'll find from these data, that's one of the most recent meta-analysis, that actually surfactant has a positive effect, both in terms of duration of hospital stay and mechanical ventilation, but as a bolus, and no effect on mortality. Why so? Because anyway, if you give surfactant this way, there will be still a lot of surfactant injuring agents over there, so able to injure exogenous surfactant exactly the same way they did for the endogenous surfactant. So anyway, meconium-induced ARDS is a sort of a primary surfactant. And it's very nice to see that on the other side of the spectrum, in terms of patient's age, adult critical care physicians, they found exactly the same. Because, for example, this subgroup meta-analysis from Dr. Toad back in Chiesi 2008 subdivided patients who were receiving a synthetic surfactant in a randomized controlled trial. And you can clearly see from this data that there is a sort of a separation here, and you start to see a signal in terms of oxygenation improvement when you look at the severe primary ARDS patients. So it seems that those are the ones that can benefit the most for surfactant. And it seems a little bit logical because anyway, the direct lung injury, the direct ARDS is something with an inflammatory process is primarily localized into the lung, and you can somehow overcome with surfactant. provided that you have enough surfactant, the right dose, the right delivery, and many other things that we don't know yet. Conversely, the indirect or secondary surfactant that can actually have a extrapulmonary inflammatory trigger and focus obviously cannot be overcome, because if the inflammatory process is still there, will still be reaching the lung, injuring surfactant and the epithelium and the endothelium. And it's nice to see that even Dr. Wilson some years ago found the same in a very, I would say, famous randomized controlled trial that got published in JAMA 2005. And you can clearly see the difference in oxygenation and even in the mortality for those children treated with calfactant, which is not even the best surfactant in terms of composition, compared to placebo. So we go back to neonates again. And if we think in terms of lavage, not in terms of bolus, so in terms of a technique that actually allows surfactant to remove surfactant injuring agents, first of all, which is something that seems logical when it comes to primary direct ARDS. Well, if you do the lavage, you see the diamond is on the left, and you actually have a reduction in ECMO need and or mortality, which is something new, because surfactant bolus did not achieve that in neonates with primary meconial-induced surfactant ARDS. There is also another nice study that has been done in an experimental model of meconium-induced ARDS. You can clearly see here that lambs randomized to have both the surfactant lavage plus followed by a surfactant bolus, they have an increment in PaO2, so a better oxygenation and even an improved compliance. So this could be actually a strategy which is very much phytopathological sound, because first of all, you remove the injuring agents and then you replace surfactant. And this is something that we could think about, but obviously is very much experimental, and there is nothing in terms of randomized controlled trial, particularly in PICU kids, to promote that. What I can tell you is that some years ago at the ASPNIC, we tried to focus a little bit about all these, and we reviewed all the data available from the randomized controlled trials in kids and then even in neonates. And you can clearly see that there is more green than red. So there is a signal anyway, meaning that surfactant in PARDS, although these trials were done with a lot of biases and problems, and don't want to talk about that because it would be really too long, but please trust me, there are a lot of biases and flows in these trials, but still you can clearly see that surfactant is going to increase oxygenation, maybe even others outcomes, and also mortality. So this is something that is telling us that, first of all, we should not put surfactant into the bin and think about that as a sort of a rescue therapy, and also that we should aim to have better design and more explanatory, less pragmatic trials, because all these trials actually mix in a little bit of everything. So primary with secondary, different type of patient, different type of ages, different types of surfactant and doses and administration. And it's a pity to say that even from the neonatal world, we're not going to have a lot of help in this regard, because trials about the use of surfactant in NARS have been limited by the fact that the NARS definition only came out in 2017. So anyway, surfactant has been trialed, particularly in small infants. Why so? Because infants are something in between and are a little bit similar to neonates. So since we are supposed to know what is the right dose for neonates, we can extrapolate and say that we could use more or less the same surfactant dose for infants. So it's just a sort of a, comfortness about that, which is not very much well grounded, because nobody did correct dose finding data for infants or even toddler and children later on. But this is it. And so surfactant has been trialed quite a lot for infants. So what is the most common, if you want, type of respiratory failure or respiratory disease in infants? Well, very often is bronchiolitis. So many trials focused on bronchiolitis and then on ARDS secondary to bronchiolitis. So sort of a bronchiolitis is actually worsened up to give a wide lung, and so an open ARDS. So in this setting, you can clearly see again the diamond is on the left. there is an improvement in mortality, there is an improvement in ventilator-free days, and there is also an improvement in PICU stay. And this was back in 2007, but another meta-analysis from a Cochrane group actually confirmed exactly the same a few years ago. And this seems to be a quite hot field, because in Italy, some colleague of mine, they started a pretty well-designed, randomized, multi-center trial about the use of surfactant from bronchiolitis. I would say severe bronchiolitis, but then if you look at the protocol, this is practically an ARDS induced by bronchiolitis. And we will see what this data, when this data will come out from the SurfaBron trial. So what is the best surfactant that should be given? Here, neonatal data can help us. You know that there are many surfactants in the world, and you can see meta-analyzed there from my group in 2019. The composition is very different, but now we know for sure what is the best surfactant, and it's the porcine one, at least for two reasons. First of all, because the concentration of active phospholipid is much higher than any other surfactant, and also, so the dilution is less, and also the concentration of surfactant proteins, particularly the hydrophobic one, the SPB particularly, is much higher than any other surfactant. I cannot talk about that because there are lots of biological data about the superiority of porcine surfactant on others, but I can only tell you that from a clinical point of view, there is a huge effect. You see the diamond is on the left again, and in neonates, the porcine surfactant over all the others is better in terms of bronchopulmonary dysplasia, but also mortality, redosing, pneumothoraces, all the acute outcomes. And this is when you treat only the primary surfactant deficiency, so a much milder disease. There is no reason to think that this is not going to be the same when you treat ARDS, which is a much worse disease when the lung is much stiffer and unfortunately much injured. The reason is very clear, as you may see here from the American guidelines. Again, it's about the concentration of phospholipid and the concentration of proteins. And so to close this section, I can only tell you that there are still some open questions, like we don't know exactly the dose to be given to children. We don't know exactly the schedule, the way and the technique of administration. And we don't know what can be the effect of newer enhanced, so more active surfactant. There have been quite a few in the pipeline, but we do not know yet. Conversely, we know that a surfactant has some effect on severe ARDS, particularly for babies, well, for children below 1 year of age and 10 kilos. And the best one to be used is obviously the porcine, which is the highly concentrated one. So we move to the steroids. And since we were talking about surfactant, I want to start with this very simple case series from Turkey, where surfactant has been admixed with budesonide to treat ARDS. The first one was a bronchiolitis, so was an RSV infection. The second one was a meconium-induced ARDS. I think that the pictures speak for themselves. It's only a case series, so obviously there's not very much of evidence, but this is very much intriguing because we now know that anyway, poractan, even the porcine surfactant can be inactivated by ARDS mechanisms. And it does not include any particular surfactant protector. So if we think in terms of enhanced surfactant, we should actually want to have, we wish to have a more enhanced surfactant. And one of the ways to get a protected and enhanced surfactant would be to use surfactant, mix it with budesonide, mix it with a steroid or other drugs that are still on the pipeline. So the Turkish people did exactly that. And it's just food for thought for now, because it's just a case series. But it's also true that, again, in the neonatal experience, the use of steroids, both intravenously or nebulized during meconium-induced ARDS, allow to reduce the inflammatory markers, as you may see here, and also the duration of ventilation, duration of ICU stay. Well, again, this is just meconium aspiration syndrome, so a particular type of primary ARDS. But that's the best that we have. And we could eventually, let's say, apply to other types of primary ARDS, even in children. But anyway, even for that particular type of primary ARDS, you see the diamond is on the left, reduced duration of hospitalization, reduced duration of oxygen support, but no effect on mortality. And in fact, back in 2012, we summarized a little bit of the evidence about that. And you can clearly see that, yeah, there is a sort of a B evidence for meconium-induced ARDS in neonates, but that's what we have. And also, there are only a few case series in bigger children, so in pediatric ARDS, describing some effects, a little bit like the ones that I showed you with budesonide, nothing more. And unfortunately, after 10 years, I can tell you that there is nothing new in the literature or nothing so new. The only thing that I can show you is coming from the adult world. It's just been published in ICM, big meta-analysis about all the trials on intravenous steroids for ARDS. I'm sure that you know the trial of Villar and co-workers in Spain, published in Lancet 2020. And you see that when you put all this data together, the diamond is again on the left. So there is an effect on non-COVID ARDS patients, but this is in adults. And particularly, there is an effect when the steroids have been given for more than 7 days. So not just one shot, but a prolonged therapy, which makes sense because if you start this therapy as a sort of a rescue therapy for the more severe ARDS, you better continue that in order to try to have an effect rather than waiting for an effect with just one dose. A recent network meta-analysis also tells us something more because, as you can imagine, there is a high variability regarding the steroids in the adult randomized control trial. And so the effect, both in terms of hospital mortality, ventilator-free days, or duration of inhalation, or incidence of infection, actually depends on the type of steroids, the dose that has been used, and obviously the type of patients, the type of ARDS we are treating. So, it's very difficult to give a firm recommendation about that because obviously all these factors are somehow creating a noise, preventing us to give you any firm recommendation. So now let's move about the pulmonary vasodilators. First of all, a little bit of pulmonary biology, because we do have a lot of pulmonary vasodilators, and each of them is acting through a different pathway. For example, the nitric oxide and the PDA inhibitors are acting through the CGMP. The nitric oxide is increasing the CGMP, and the PDA inhibitor, they're actually reducing the breakdown of CGMP, so increasing the level of that secondary NO messenger. And then we have the bosentan and the tetrasentan, who are inhibitors of the endothelin-1 pathway, receptors particularly. And then we have the prostacycline, and particularly the iloprost, who is increasing the CAMP, exactly like adenosine, was being used quite a lot by Peter and the Geneva group a few years ago. So you see, these drugs have actually different pathways of action, which also means that they could actually have synergies between them, which is very much interesting to be remembered. And I would say even not so exploited, not very well investigated so far. So a few months ago, we published this protocol. As you may see in this picture, we provided you with a sort of a map with all the interaction of these drugs. And you can clearly see that some of them are synergic. So you have an interest to use the ones that are crossing each other with a green square, because this way you can have a synergy and possibly lower the shunt fraction and the pulmonary hypertension related to ARDS when just one of these drugs is not actually functioning. And we actually do that for kids, for neonates, at the border of ECMO, trying to reduce the need of ECMO, but this is only because we have ECMO very close round, and you should be very careful to use all these pulmonary vasodilator if you do not have ECMO. I mean, if you have ECMO, because you shouldn't delay ECMO. Obviously, if you do not have ECMO, you are a little bit more free to use these drugs. But anyway, a correct protocol and procedure for ECMO referral should always be in place and enforced. So iloprost is the one that we use the most as pulmonary vasodilator. First of all, because of these synergies, but also because Peter demonstrated more than 20 years ago that actually has the same power than nitric oxide, as you can clearly see from this paper from Circulation 2001, and also because it's very manageable, as a quite short effect time. So you gotta nebulize it every 2-3 hours, but it's very easy to be nebulized. There is absolutely no side effect in terms of systemic pressure and in terms of any other side effect. And it's also quite cheap. So we use that as a rescue for NO for several cases, as you may see here. And it's something that has been studied quite a lot by Peter's group some years ago, as you can clearly see from this Swiss meta-analysis. But then again, even with the meta-analysis, you can clearly see that the majority of studies about the use of Alloprost have been not controlled, not randomized. So the evidence is pretty low, but it's very manageable. And we use it with a high frequency membrane nebulizer that you can clearly see can be applied even in high frequency ventilation. We now have many data that I cannot show you, but particularly coming from the Di Blasi group in the US, demonstrating that this type of nebulizers are able to nebulize Alloprost effectively, even during HFOV, which is something we didn't know like 10 or 15 years ago. And then the interest of Alloprost is also that since it can be nebulized by this type of nebulizers, you can even use it in a non-invasive way for those patients that you can actually try not to intubate as much as possible, like the immunodeficient one, like the oncological one, or like, for example, the infants and toddlers with bronchopulmonary dysplasia, like this one, as you can see. Because obviously, when a patient like this one have ARDS because of RSV, because of flu, or because of anything, the last thing you can you want to do is to intubate it, because then it's going to be very, very difficult to extubate him. You can clearly see the film. And when we use in a pretty large case series, but it's still a case series, when we use the Alloprost in conjunction with NEVA non-invasive ventilation for this type of babies, you can clearly see here that we achieved an improvement in PF ratio, and also we achieved a decrement in the ratio between pulmonary and systemic pressure. So, reestablishing a good hemodynamics for these patients. And also the comfort in terms of respiratory rate and heart rate was pretty good. It's nice to see that a similar uncontrolled experience has been published more recently in adults with ARDS. And you can clearly see that the oxygenation was going up with the Alloprost nebulization, and the systemic mean arterial pressure was absolutely stable, was flat. So there is no systemic effect of Alloprost, as I told you a few minutes ago. And the adult and the neonatal data are going towards the same direction, are very much consistent. And this is the best that I can tell you for children, because again, unfortunately, the very pediatric population right in the middle, it's a little bit scanty of data about that. Here is another trial, very short, very small, but it's a crossover trial actually. So at least it's sort of randomization in adults with ARDS. And here you can clearly see that the increment in oxygenation seems to be there, particularly for less severe patients in terms of compliance. So those patients with a less stiff lung. It seems logical to me in terms of physiopathology, because obviously Alloprost is improving oxygenation by reducing the shunt fraction. But if you have a part of your oxygenation deficit coming from the actual parenchymal disease, because your lung is very much stiff because of the inflammation and because of surfactant injury, well, it's not the pulmonary vasodilation that is going to improve the problem until at least you open up the alveoli with a good high frequency ventilation or pronation, or the combination of both, or whatever. So when you achieve a good recruitment and so a better compliance, then the Alloprost can be an additional tool to increase your oxygenation. There is actually now a phase 2 trial that is ongoing for Alloprost in adult ARDS, which is very much interesting. It's a European trial that you can see here. I don't know where the results will be available, but that particular trial is actually exploiting Alloprost not only for its pulmonary vasodilator effect, but also for its new anti-inflammatory effect in the lung. So it is totally new. We'll see what is going to happen with that. For now, I can only tell you that ESPNIC issued some guidelines about pulmonary vasodilators in 2004. We never actually renewed these guidelines later, but according to what I showed you so far, actually there is no very big news. So according to these guidelines, nitric oxide is obviously the first-line therapy, both for neonates and infants. I didn't say very much about nitric oxide because I assume that you already know, you have everything about that. But regarding prostacyclin in general, and so also iloprost, there is a chance that can be transiently useful, and we only have one trial in children demonstrating that in terms of oxygenation. So the guidelines are only telling you that it's something that can be tried when the patient situation is too much severe. So we stick with some open questions. We don't know exactly the dose. We don't know what type of molecules is better than any other. We use very much iloprost, as I told you, because it's very much manageable, but there is no preference, no formal preference to be given between the different drugs. Maybe for the patient selection, it's better to use iloprost when the patient has already been recruited, as I showed you before with this data from adults. But again, no pediatric patient data, and we don't know anything about the duration of the therapy to be applied. I can only conclude suggesting you to become an ESPNIC member. We're going to work about this area and many other and even more. You know that ESPNIC grew up quite a lot in the very last years, and hopefully in the future as well. We have more than 20 key euros of research grant per year. We're going to launch a new journal, which is called Pediatric and Neonatal ICM very soon. And we have a lot of simulation training at our face-to-face congress is going to held in October in Barcelona. And the next one will be in Athens, 2023. And you are more than welcome. Thank you very much for listening to me.
Thank you, Daniel. Can I open the video? Taufik, please open the video.
Sorry?
No, just open the... Daniel, that was an exceptional respiratory effort from your side, considering you're so sick. But it was a wonderful session, Daniel. Thank you for joining us despite being sick. And this conference was so elegant that the future one decade of research work, what we may succeed in the next one decade may be evident shortly. So I leave it to Junaid. Junaid, please take over from me.
Okay, so thank you very much about this thing. So now I will start with, of course, Dr. Daniel, that the availability of aerosolized this iloprost is how it is. This is available nowadays. Especially, I'm talking about the infants, which is more prone to the bronchiolitis and all those.
Iloprost has no place in bronchiolitis. Bronchiolitis is not a ARDS, it's just an airway disease. And usually can be treated just with CPAP very effectively. Everything I told about iloprost is when you have a severe ARDS, so a white lung, with a parenchymal extension of the disease.
So the other thing is that, let's say, move to the, with the ARDS and they have the component of PPHN, okay? So do you recommend this iloprost aerosolized in that condition also?
Cannot do that because the first line for this is always no nitric oxide, unless you don't have nitric oxide. Then in that case, it's better use iloprost than anything.
Okay, so the other thing is that, for the neonatal RDS, we give the surfactant. So is there any time for giving the surfactant in the ARDS? The early we give or the later we give, or we will see how the baby they're doing?
There's nothing about the timing. That's a very good point. I tend to say that obviously, if you give it too late,
Mm-hmm.
when you are already in the second phase of ARDS with fibrosis, you cannot expect any miracle.
Mm-hmm.
But then it could be very difficult to understand what is the right point to give it.
Yeah, and you showed the slide of different surfactant. So, for example, like in the newborns, I mean neonates, the poractin alpha is a little bit more efficient, or efficacy is high. But what about the in the ARDS in a bigger kid? If we try to give surfactant, is there any make a difference in to come out of
but
the
to
ventilation?
understand that, I should have showed like 100 slides of pulmonary biology, and I didn't have time. The only thing I can tell you is that every type of surfactant that is injected into an ARDS lung is going to be somehow deactivated and injured, okay? Now, also poractin alpha, but because of its composition and because of the possibility to inject a higher dose, poractin alpha is going to stay more and is going to be less deactivated than the others, even in ARDS. This is known from a biological point of view, has been shown in many, many animal models.
Yeah.
And we should consider that. I'm sorry, I have a call from the ICU. Give me a second. Wait.
Maybe we can move on to another question in the meantime.
Yeah, good idea.
Yeah.
To Martin and to Dr. Peter, has sildenafil been used in pediatric ARDS successfully? IV sildenafil?
I'm sorry.
Any studies?
Okay, Daniel is. So what about the steroids? Okay, the use of steroids in ARDS. What do you think? This has a long-term effect on the kids or not? If we give the steroids, and it is again the dose base as like in the BPD.
There are no data about long-term because anyway, there is not so many data about PARDS and steroids, but I tend to say that this is not a problem because anyway, we're not using steroids for such a long time. Okay. And we're talking about so severe patients that we shouldn't worry about that. We should worry first of all of saving the baby.
Sure. And the other thing is that the inhaled steroids versus IV steroids, is any difference, anything?
There is no data at all.
Okay.
There's no data at all telling anything about what should be preferred between the two. But again, since at least we do have some doubts about the actual delivery of nebulized steroids, and we're talking about the more severe patients, I believe that if we give steroids to PARDS kids, we should give them intravenously, exactly like it has been done in adults.
Okay. Yeah, Rajiv, you have some question?
Yeah, in the neonatal world, sildenafil has worked well intravenously in pulmonary hypertension. But what is the experience in the pediatric intensive side? This is to both Daniel and Martin.
With what? Sorry? What?
Intravenous sildenafil.
Which drug you're referring to?
Sildenafil.
Sildenafil.
Oh. Well, first of all, in PARDS, there is nothing. There are a little bit of data in neonates, but let me tell you that I do consider this option inferior to the molecules that I showed you for several. Sorry? Can you hear me?
I think.
Yes, doctor.
We can hear you, Daniel.
Yeah, now you.
For several reasons. Intravenous sildenafil is not a good option for several reasons. First of all, because it's intravenous, which means that it's going to reach the lung on its entirety. So you're going to vasodilate areas that are well aerated and also areas that are not well aerated. So you can even have a sort of a paradox increment of shunt fraction, which is not a good idea. Conversely, when you use a pulmonary vasodilator that is direct into the lung, like nitric oxide or alloprost or anyway prostacyclin, this is going to reach only the alveoli that are well ventilated. And so it's improving the ventilator perfusion mismatch. Not to mention the fact that sildenafil, obviously IV, is going to have some systemic effects on mean airway pressure and systemic perfusion, which is something you don't see with alloprost and the local pulmonary vasodilator. So this is why we almost never use it, actually.
Yeah, Rajiv, I have a question regarding this. The IV sildenafil, the efficacy of oral sildenafil, there's a meta-analysis in the newborn with the PPHN is the same. So why you are insisting on IV?
That is because Steenon study, because myself and Patrick McNamara are working on a formula.
Okay.
We do not use nitric oxide in low middle income countries. So,
but this is very expensive, you know, IV sildenafil.
Yeah. No, Steenhorn had used one intravenously for 3 hours, and that produced good serum sildenafil levels of 2 nanogram per deciliter over a short period of time, maybe within half to 3 hours. Oral sildenafil takes at least 1 day to reach a critical sildenafil level. So that's the time we prevent rebound pulmonary hypertension in PPH.
Yeah. So, Martin, there is a question about from Dr. Ayman Rahmani that is there any minimal mean airway pressure to use with a certain amplitude to give most efficiency of the ventilation? I mean, the minimal airway pressure actually you want to know.
Well, you have to distinguish for the oxygenation and the ventilation, and a minimal airway pressure. There is no such number. The only thing is that it cannot be lower than the mean airway pressure on conventional ventilation, because I've seen that happen. So if you're on a mean airway pressure on conventional mechanical ventilation, let's say about 15 centimeters of water, your mean airway pressure on high frequency should at least be somewhere to 5 to 8 centimeters higher than what you have on conventional ventilation. Otherwise, because your tidal volume, your stroke volume envelope is really small, otherwise you will get de-recruitment. And it depends on the lung mechanics. It depends on where you are in the disease trajectory, on which day. So there is no magic number necessary, except for the only thing that it can never be lower than unconventional. I don't know, Peter, if you have any additional thoughts on that.
I think the question was addressed a little bit different. The question was, is there a minimal air vacation in relation to the amplitude you use? And this is an ongoing discussion all the time. It comes from very old times when they used in the early trials very low frequencies, clear that the amplitude, because of the pressure swings that are transmitted, might create negative intrapulmonary pressures. Nowadays, where we use high frequencies, we have much less pressure transmission. So the question or the fear that there may be some airway collapse does not exist really anymore. So I never saw in my experience the phenomenon of choking points. So I think it's something you have to forget. Trial in your mean air pressure according to oxygenation needs, dial in your amplitude at the highest frequencies to get your CO2 out.
The other question is a general question, Peter or Martin, anybody can answer that the role or the place of any hypercarbia or permissive hypercarbia in ARDS, in pediatric ARDS, or it is no for the pediatric age group.
Peter, you go first.
Oh, that's yours.
Well, to put it very easy, the role of hypercapnia, if there is no strict contraindication for hypercapnia, let's say the patient with severe traumatic brain injury or the patient with severe pulmonary hypertension, where you want your pH to be within the normal range, then to put a real binary, I don't care about CO2. It's not for, I'm not talking about preemies or whatever, I'm talking about the pediatric patient. So as long as the pH is, and I tend to be a little bit liberal on the pH than some of my colleagues, but as long as the pH is, let's say, above 7 15, 720, then it's fine. I'm not aware of any studies, but maybe Heidi or Peter know studies that have shown a relationship between high CO2 and adverse neurologic outcome in PARDS patient or any other ventilated kids in later on.
Okay.
There's no data about this. Just to remind you, when we talk about hypercapnia, we talk about permissive hypercapnia, which means you are urged to accept. It's not the treatment concept, which is often misunderstood. And there is no data showing that allowing for high CO2s is improving outcome. It was just combined with the ventilator settings behind that. The major thing for having better outcome was the more protective ventilator setting. So permissive cap is not the therapeutic approach.
Okay. The other question is regarding the overall management of the ARDS. Mostly people are sending the questions that they are related to the infection or the pneumonia, or the COVID. So how aggressively you think that we should treat the infection, and then we also think about how you relate these two together, especially in the young pediatric age group. I'm talking about 1 year, 8-month-old.
Well, Heidi, take it away.
So yeah, I think mostly they think that this is pneumonia first and then it happens. So what do you think about that?
So I was on the ICU call for a quick second. So the question between pneumonia and sepsis-induced ARDS, that was in the chat. Yeah,
exactly.
So, you know, I don't think we've, in all of our studies that we've done, we really haven't necessarily seen, we've definitely seen an overlapping in that pathophysiologic basis. And as I showed you in the talk, there definitely are some more elevations of the vascular endothelial injury markers in sepsis patients or indirect ARDS than the primary pneumonic patients. In the end, in terms of severity of disease and outcomes associated with that, you can get to very high levels of all of those markers in both pneumonia and sepsis, and clearly pneumonia is a form of sepsis. So it's a little bit smooth across that. Interestingly enough, when we put in our latent class analysis, the cause of ARDS was not as predictive as the levels of these markers. So we are going to see individuals who are able to be more or less hyperinflamed no matter what severity of ARDS they have and what the cause is. So, so I think this more to come as so much of this discussion is, but I think it's highly relevant. And to go back to that last question, and I'm unfortunately going to have to jump off this Q&A in a minute as well. But Brian Kavanagh used to spend an awful lot of his work on permissive hypercapnia and the potential benefits of hypercapnia in terms of NO production in the lung. And he's obviously no longer with us, but that was a whole field of his study, is the impact of permissive hypercapnia, not all of which are negative at all. So,
yeah. So thank you very much, Heidi. And I think most of the people has to go now. So Rajiv, you do your concluding remarks.
I will conclude the session. So today we had a very wonderful session. It was almost like a brainstorming session. You know, almost all the countries have participated in our network. And I think I already mentioned what we talked today would be probably the research results will be out in a decade. But overall, I think this was one of the best composite symposiums on ARDS I've seen. By almost all aspects we have touched, and the questions asked were very meticulous and answered very precisely. And the gray areas were identified, and we know where we are to improve, etc. And a lot of directions are shown in the ventilatory strategy and in the drug therapy, which we are also interested for the next few years. Thank you so much for coming, and We look forward to meeting you in some other network.
Thanks a lot, Rajiv, to arranging all this. And I must thank all the international speakers. And I mean, it's really great. And all the participants, it's more than 680 participants. And there are a lot of other questions. But of course, I'm seeing in the chat box, everybody has other commitments. So we will not keep you there. So thanks a lot, everybody. Peter, Martin, Heidi, and Kiran Moray, and Dr. Daniel, everybody. And see you, inshallah, next year.
Dr. Deepu will give the vote of thanks.
Just one last thing. I have given my book to all of you, and we are going for the next edition. So all of you are welcome to give me suggestions, because the next edition is going to come within 1 year. I want all your valuable suggestions. Thank you.
Sure.
Yeah.
Thank you.
Drop on the vote of thanks, please, Doctor.
Thank you for having me. And if the audience has any questions, they can shoot me an email anytime. Happy to answer through email.
Thank you, Martin. Thank you very much.
Okay. Have a great day.
Have a great day. Bye.
Thank you. So let me just give a very brief word of thanks. So first of all, the most foremost, Dr. Rajiv, who has been the pillar stone for organizing this event. His energy was infectious. We all got charged up with that. And thank you for bringing all these great speakers under one roof for this program. Thank you, Dr. Rajiv. And Dr. Ramesh, who has been, in spite of his very busy national commitments, he has always been a part of our IAP Emirates programs. Thank you for all your support and inspiration. And all the senior members of IAP, including Dr. Sridhar, who has been there throughout for this program. Thank you very much. And a big thanks for all the speakers who gave us such beautiful talks. Dr. Peter, Dr. Santosh, Dr. Heidi, Dr. Martin, and Dr. Daniel. And Dr. Daniel and Dr. Heidi were on call as well in between all these busy schedules. And thank you again for all the moderators, Dr. Kiran Moray, Professor Iqbal Menon, Dr. Praveen Kumar, and Dr. Junaid, who all are very eminent in this field and gave that time to spend with us. And thank you for all the participants who made this very interactive session and for attending this and making it a success. Last but not least, Tawfiq, who has been the pillar stone in arranging, in coordinating in the IT side, who is the country head of the Vitabiotics. Thank you for your strong support for this event. Thank you all.
Thank you and good night, Dr. Peter, Dr. Kiran. Thank you and good night.
Good night to all. Thank you.
Good night. Good night all.
Good night, everyone. Thank you.
Bye, Sridhar.
Bye.